me is Miss.
Rima Sivakuti.
We are the host for this workshop. On behalf of the organizing committee, we are very happy and privileged to receive you all here. Our theme for this year is Role of the Nurses in Telemedicine. After the huge success of the first and second telemedicine workshop, which was held 4 years back, this year's third national telemedicine workshop is jointly organized by Temson, APAN, NREN, and TEMDEC, and supported by NTA, NTC, WHO, Nick Simons Institute, and NPICS. As we all know, telemedicine has been practiced in Nepal by a number of institutions and individuals for more than a decade. While the way telemedicine is practiced, many vary a lot. We feel that better cooperation and coordination among the practitioners can create the synergy and set a standard goal. In the changing political scenario of Nepal, and towards the mature practices of federal context, Nepal also has acquired equity in health with universal health coverage and access to quality healthcare.
Indeed, no one must be left behind for sustainable development goals. This workshop is a platform that brings international and national professionals involved in telemedicine together to share their experiences and expertise for the betterment of the telemedicine practice in Nepal. We are so glad that this year we are joined by around 100 participants from around various parts of the country, and we are also joined by our delegates from Japan. We also have participants joining remotely from different other countries. Now, without further ado, we would like to welcome Professor Dr. Saroj Dhital, the founding chairman of Telemedicine Society of Nepal, Vice President of FECT Nepal, and to acquaint us and deliver welcome remarks and workshop introduction. Please give a round of applause.
Thank you, dear, for asking me to welcome all the wonderful people from at least half of the world. And thank you, the organizing committee, for giving me this responsibility. I thought that now it's time for me to stay back and enjoy life at home. It's not to say that I'm not enjoying being with you. I'm a little bit after that you are making me young again, and that's a lot of extra responsibility. I welcome you from the bottom of my heart. And that's not only a ritualistic remark, but telemedicine for me is an act of love. An act of love that allows people to reach the unreachables or unreached people, to extend your love beyond the physical barriers, and a platform where the human sentiment and technology can meet. Since all of you are so active in this platform of telemedicine, you are really respectable people, and it's very nice to be able to welcome you in this Kathmandu morning. Having said that, I am sometimes a little bit worried that telemedicine can be hijacked by the market. Whether we like it or not, now it is the market which is ruling the whole world. And whatever we do, our responsibilities, our act of love, everything, all the human sentiments are also being hijacked or kidnapped by the market. And that's quite scary for me. It's not de-recognizing the role of market, but when everything is ruled by dollars, then life becomes ugly. So I sincerely hope that all of you who are so actively engaged in the activity of telemedicine, please try to save it from the vulgar market and bring it to the domain of the highest sentiments of the human beings, that is love and kindness. When I was also a little bit active as a clinician and in telemedicine activities, I have found that it's very difficult for people to understand telemedicine beyond the borders of technology or biomedical limitations. While practicing telemedicine, I have experienced myself that there are so many non-technical issues and human factors which has to be addressed. In the last few decades, information and communication technology has advanced to unthinkable, height. It has been much cheaper in comparison to the past. It is more easily accessible. The technology is ever developing. But in spite of all these things, why still so many people have to go to the hospital to get simple health services? It's not, the technology has advanced. It is advancing in a higher and higher, more and more accelerated speed. But the way people should benefit from it, especially the sick people, the needy people, it has not been at par with the progress of the technology. And I wish I am wrong, but I think that then the clause of the vulgar market, when that starts acting, even the technology cannot do much. So I hope that the new generation of wonderful people who are trying to bring telemedicine to a greater height, I hope that you will give telemedicine a soul, a human soul, where love and kindness is there, a soul where you can see responsibility towards the society. I think that, since I'm a retired clinician, I'm not doing much now. So that's why I can be so frank to you. I think I don't need to say more about the introduction of the workshop. I think next Professor Moriyama and Dr. Uday, they are going to talk about it. I am seeing that everything has been very well organized and well managed. So I don't need to deal with that. I have not done anything. I have not contributed a single thing for this wonderful workshop and conference. Thank you very much. once again welcome all of you to this Kathmandu Valley. A little bit polluted, but it's still very beautiful. And for all our cyber friends who are meeting us in the cyberspace, welcome all of you too. Thank you.
Thank you very much, Professor Dr. Dital, for that inspiring message. And you are retired, but not tired. We always inspire by you. Thank you very much, sir. It is the honor of us to have opening remarks of the Professor Tomohiko Moriyama. Professor Moriyama is the president of Telemedicine Development Center of Asia. Let's welcome him with a huge round of applause. Thank you.
Hi, good morning, and police friend and Asian friends, and maybe good evening to Latin friends. Okay, thank you for joining the 16th ATS. Oh, sure. Okay. And before starting my talk, I'd like to show my sincere appreciation to Dr. Dital, Dr. Udaya, Mr. Rajan, and their colleagues who have made a great effort to organizing this fantastic symposium. So I'm so happy to meet many friends in Nepal, and also to know the many new people here in the venue. Since 2020, this ATS is held totally online, but this is the first time to meet in person since 2020. So it's really nice. Okay, this Asian Telemedicine Symposium was started in 2007 so far now, when the telemedicine was quite immature. Very limited people know the situation of the telemedicine situation and what we can do using the developing internet. So we organized this symposium for the first time to share the knowledge and experiences in each country to expand telemedicine activities in the world. And already more than around 15 years have passed. And of course, a bit thanks to the COVID, the telemedicine is now quite popular, both for sharing the knowledge for doctors and medical staffs, and also for the patient. But regarding the remote patient care, it is not so familiar maybe in the world. Of course, at least in Japan, no. So still, we should make a great effort to provide our medical technique and the knowledge to the citizens in the rural area. And also we can provide a medical treatment or others to those kind of people. Still, telemedicine, of course, telemedicine is a very, very important tool, as Dr. Dital said. So we should think how to expand to the remote patient care now. So from the viewpoint of this, the theme of this telemedicine as ATS is quite important. The theme is role of the nurses in telemedicine. To expand more and provide medication to the rural patient, we should need the help of nurses. So the situation is same. Also, in Japan, we would like to have many help from nurses. Without nurses, we can do nothing. So I sincerely appreciate Dr. Udaya to set this theme in this ATS. So I hope to enjoy the presentation from nurses in Nepal and other countries, and also would like to know the telemedicine situation in various countries. So I would like to learn a lot with you guys here, and also would like to have a fruitful discussion. So thank you again, and let's enjoy.
Thank you very much. Yes, nurses are the backbone of the community. Yes, so the theme is very true, the role of the nurses in telemedicine. Now I would like to call upon the stage Dr. Uday Koirala for deliver opening remarks. He is the president of Telemedicine Society of Nepal and HOD of Surgery Department of Kathmandu Model Hospital. Let's welcome, sir.
Thank you. All the guests, my seniors and colleagues, it's my great honor to be here as a chairperson of Telemedicine Society. And it is because of our seniors' great effort that has been made on telemedicine. Now it's growing up. There are still many things to be done. But at this conference, there were so many participants eager to participate in this activity. And now the area of telemedicine is also increasing. So to be the part of the Telemedicine Society of Nepal, it is always a great pleasure and honor for me. This time, when we are discussing about the telemedicine, now we can see that because of COVID also, everyone has realized the importance of telemedicine. Telemedicine, we were only thinking about rural health, remote areas, but now the area of telemedicine has grown up. Now we realize that it is also very important in urban area as well. There are so many senior citizens, they need telemedicine. There are so many pregnant women, they need telemedicine. There are so many children, they need telemedicine. And actually this telemedicine can help a lot. It was not in government's priority. It was not in priority of so many institutes. They are still not very much eager to invest on telemedicine. But now when I went to so many government officials, so many institutes, they are slowly trying to invest, at least budgeting some fund to telemedicine. And that is a good thing, but the activity is very slow, but still there are some funds now which can be utilized in telemedicine. This time also, there are so many presenters, they are going to present on this role of nurses in telemedicine, role of paramedics in telemedicine, this telemedicine in urban healthcare, telemedicine in pregnant women, in this SDG. So there are so many areas of telemedicine, and even the insurance should cover telemedicine. All the healthcare professionals who are involved in telemedicine, they also should be reimbursed. It's not free service. We must know that it's not free service, but patients should not be charged, of course. And government and organizations should fund to help telemedicine to grow, then only it will grow. So that will be the theme of this workshop, I think. And we'll learn many things from many speakers, national and international, on-site and online. So we are very much excited to say you that there are more than 100 participants on-site and online, and from so many countries also. So thank you, ATS, especially Kyushu University, who initiated this Asia Telemedicine Symposium. I also got chance to go to Kyushu and participate in one of the ATS. And it's their great initiation that
is inspiring us to develop, to promote. And similarly, there are so many Nepali government officials now, Ministry of Health, they are helping us a lot. WHO Nepal, they are helping us a lot. Nick Simons Institute, they are also helping a lot. They are especially involved in rural healthcare, and I think it is one of their priority, telemedicine, to connect all the MDGPs who are working in rural areas. And now MDGPs are also excited to be connected through telemedicine and to have case discussion, to have patient referral system. And government is also now has come up with a guideline, and that I think will be improved in the years to come. Nepal Medical Council has also come up with a guideline, and we were also one of the important partners in producing the guideline. So Nepal Telecom Authority, Nepal Telecommunication, they also have now prioritized one of the part as digital health and telemedicine. So the things are improving, things are going on, developing, and thanks to our seniors who had a lot of effort, a lot of pain to develop this. Thank you.
Thank you so much, Professor Moriyama and Dr. Koirala, for your wonderful opening remarks. We have indeed accomplished many things in the field of medicine and have added many feathers to our cap. One of them is telemedicine. With that note, ladies and gentlemen, let's move on to our first session, that is telemedicine in different countries. In this session, different telemedicine end users will present the scenario of telemedicine in their country through virtual connection. May I now invite chairs of the session, Dr. Saroj Dhital and Dr. Mohammad Qasim Saha, to conduct the session. As already introduced, Dr. Saroj Dhital is a founder chairman of Telemedicine Society of Nepal and vice chairman of FECT Nepal. And Dr. Mohammad Qasim Saha is a senior program manager at Nick Simons Institute, MD in general practice of NAMS, fellowship in diabetes management from CMC Vellore, and 12 years of experience as a health service provider in different levels of the hospital. Thank you.
Good morning, everyone. First of all, I would like to thank organizing committee for this opportunity and this responsibility. We are very much delighted to be here today on this 16th Asia Telemedicine Symposium and 3rd National Telemedicine Workshop organized by Telemedicine Society of Nepal and Nepal Research and Education Network. During this first session, we will listen about the experiences from different people, and we will try to entertain on ideas, opportunities, and challenges on telemedicine. And on this session, we have 7 presentations from different people. So without delay, I would like to start this program, and I request our seniors, Dr. Saroj Dhital, to lead this program.
Thank you, Dr. Qasim. So, Dr. Sudeep, are you ready? I hope that you will be in time. It is the ugliest thing is to remind the presenters of the time. And we don't have to do that, I hope. while they are still preparing for the slides, let me take the opportunity to introduce Dr. Sudeep. Everybody can see that he is a really, handsome person. I will not reveal everything about the ladies around him. Sorry, I didn't say anything, but he is a very a good surgeon. He is now a consultant surgical oncologist in Kathmandu Model Hospital. And he has been actively involved in telemedicine activities for more than 5 years. Sometimes he has also represented Kathmandu Model Hospital and Public Health Concern Trust and attended a number of APAN meetings in the past. I have been knowing him from when he was a very, very fresh surgeon. And I have always felt very proud of him to have him in my then team was a real pleasure. Okay, so please.
Respected chairperson and all the participants of this symposium. Good morning to all. I'm Dr. Sudeep Sakya. Dr. Dital has already given a brief introduction. So I'm going to kickstart this workshop, and I'm going to talk briefly about the telemedicine in Nepal. I'd like to give some brief overview of how we started and where are we now. And I'm sure as we move on in this telemedicine, different presenter will be sharing their own experience. So if you have been in telemedicine, we will know this famous personality, Dr. Bingmar Sherpa, Munira Sakya, Dr. Mahabir Poon, and Dr. Saroj Dital. We can consider them like pillars of our telemedicine, or like fathers of telemedicine. It's because of them that their vision and their hard work that we are here right now. So if we talk about telemedicine in Nepal, like history, the Ministry of Health, they started the rural telemedicine program from 2 districts back in 2010. Right now, it's already expanded to all the 7 states of the Nepal. So before the MOSP, there was a project, HealthNet project of the rural medicine, telemedicine, and hospitals like Om Hospital were also providing telemedicine services in various departments. But the real when started was by Dr. Mahabir Poon and the Nepal Wireless, who set up the connection of the to the rural Nepal. So there were many challenges and difficulties setting up the connection to the rural areas. If you have attended some of the lectures of Dr. Mahabir Poon, you have seen might have you seen these pictures of setting up this long range testing back in 2002 at Mohare. All these our mountainous region also provided some very difficulty in setting up these connections. So finally, with the help of NREN, by 2006, Kathmandu Model Hospital was able to establish a communication with the Gauri Sankar General Hospital in Dolakha. So Kathmandu Model Hospital worked as a hub. So since then, we have been having regular telemedicine session between the remote health center and Kathmandu Model Hospital. So we used to provide teleconsultation, and we even used to do rounds, morning rounds at the beginning of this program. So by 2011, there were many other remote areas were also connected by 2001, and the telemedicine activity was slowly started to pick up. Our work was also recognized by our national news like Nepali Times, which published this article about a long distance medicine, where they talk about initially there was difficulty in internet connection and so on. So about that time also, there were other organizations also like Ask Foundation, which also provided telemedicine services from 2009. So in Kalikot district, Kalikot Clinic. So then after connection with the TEIN, then we were able to expand this globally. We were able to connect further to various medical universities in Korea and Japan. And from then onward, we were able to share knowledge as we also were able to save expenses, because to attend the conference, we didn't need to go to abroad, because we could virtually attend and gain experience and knowledge from these conferences. So thereafter, like from other hospital also, this was a news published in Kathmandu Post, like the Patan Hospital also started the telemedicine services back in 2011. Dharan, I think Dr. Pramendra will talk about this, in 2015 began its telemedicine services. And so as the Beer Hospital, even Institute of Telemedicine also started the DIT back in 2008 and started the telemedicine services. So after this, we were able to conduct like all this inter-hospital sharing department in different hospitals. So, and not just in the medical field, even in the information and communication technology, the telemedicine topic was discussed in their conferences also. It was also recognized by like a non-international, non-medical fraternity also. This was the article published in Denmark, which also talk about this telemedicine activities in Nepal. Now, there were very benefit of telemedicine, especially it has drastically improved the healthcare system in Nepal. Like, especially it has improved the telehealth for women and girls. They were able to discuss their sexual and the reproductive health problem. There was this article published in Telematics and Informatics. Okay, sorry for the interruption. So there was this article published in Telematics and Information, which talk about telemedicine helps to overcome gender barrier in healthcare, which won the Okay. So also the telemedicine also help in the appropriate referral of the patient. Yeah, Baba. Yeah. Okay. So there were with telemedicine, there were also various challenges, and this was the systematic review, which brief like what are the challenges in terms of, there were challenges in terms of technical, like a geographical, because of the no proper roads, lack of transportation. Also, there were lack of supportive policy, like Dr. Uday briefly mentioned about it. There were also lack of skilled manpower in the rural areas. The funding was the issue in some places. But there were opportunities with the telemedicine in terms of education, training, and awareness. There was a cost-effective treatment because patient didn't have to go all the way to the center for the treatment. And also there was equity and the increased health access. So by this time, there were many like organization and hospital which were providing a telemedicine services. So, but there were no any coordination. So this Telemedicine Society of Nepal was established to bridge a proper coordination and organization among the organization which are working in the field of telemedicine and e-health. So we were this Telemedicine Society of Nepal and REN were able to organize this first telemedicine national workshop back in 2016, and then the second in 2019, where we were able to discuss from the medical side, from the engineer side, they were able to discuss all the telemedicine activities and how we can develop. But the process was slow. But then after this, the COVID pandemic hit, and it was a slight of a blessing also in the field of telemedicine, because because of this, more people were using now the telemedicine. We knew the importance of telemedicine after the COVID pandemic. So this study have shown that telemedicine usually save time, effort, and money, especially for people living in the remote areas. Now, because of this, now we already have our governing body in Nepal Medical Council already have a telemedicine guideline for us. And even the government has also this telemedicine guideline. Now, in future, hopefully in our curriculum also, we could include telemedicine in both engineering and the medical side. So the future looks good for the telemedicine. So I can tell Dr. Dital that he can enjoy his retirement happily, because the future is in very good hands among all the young and the very active members of who are actively participating in telemedicine. This was just last year a digital telehealth conference which was organized by Dharan, where we were able to again share the various telemedicine activities all around the world. So right now the field is even increasing. The telemedicine is integrated in the electronic health record, which has made the life even easier. So hopefully in soon time, they may not need medical anymore. It might be all AI also. So with this, I'd like to end my talk. Thank you very much.
Thank you, Sudeep. Just in time. Very proud of you. के गर्ने क्वेसन्सहरु अहिले गर्ने हो र पछि गर्ने होला पछि लास्टमा ओके
Our second presentation is by Dr. Omen John. This will be virtual presentation, and he's going to talk about telehealth for strengthening primary healthcare service delivery, evidence from the COVID-19 pandemic in Southeast Asia region. Dr. Omen John is a physician researcher, elected fellow of the International Academy of Health Science Informatics, associated editor of Oxford Open Digital Health, and conjoint lecturer of Faculty of Medicine, University of New Wales, Sydney, and professor at Parana School of Public Health. He served as an international advisory board of Commonwealth Center for Digital Health. Now we are going to listen Dr. Omen John. Dr. Omen John.
Namaste, Ajur. Thank you for this opportunity. I am grateful for giving me this chance to share about a study that we did along with WHO Southeast Asia Regional Office. I am just going to start sharing my slides. Please confirm that you are able to see it. I would need to be allowed to share the slide. Host, please enable slide sharing. Apologize for this. Thank you. Could you please confirm that you're able to see my slides?
Yes, John, we are seeing.
Yeah, thank you. So this study is called REACH, or Role of Telehealth in Enhancing Access, Ensuring Continuum of Care and Supporting Health Systems for Primary Care in the Southeast Asia region. This was undertaken by George Institute for Global Health and on behalf of WHO Southeast Asia Regional Office. In this study, we used the WHO Digital Health Guidelines Development Framework, which divides the domains into interventions that face clients, interventions that are primarily for healthcare providers, interventions that are primarily focused on health system managers, and fourth domain being data services. So we identified in consensus with several stakeholders that there were three thematic areas that were important to study. This was in the context of the COVID-19 pandemic. So we were interested in looking at the telehealth uptake in the routine health services delivery before COVID, during the pandemic, and what does it look like for the future. So this was primarily looking at utilization of telehealth model before and during the pandemic and looking at what are the emerging trends. Secondly, we were interested in understanding what are the enablers and barriers to implementation, as well as what is the scale up of telehealth intervention. As all of us are aware, telehealth is nothing new. This has been around for several decades. However, the pandemic has really given us an opportunity to relook what were those systemic enablers that were probably lacking that COVID brought along, and how systems, both primarily from the governmental side and the regulatory side, that enabled quick deployment and massive scale up in response to a public health crisis. And what is the impact of telehealth on health services delivery? So quite often when we look at telemedicine, we look at from a point of a person who is in a remote area just trying to get care, and it's a transactional one-time activity. However, when we look at it from an ecosystem perspective or from health service delivery perspective, to use as a tool for strengthening primary healthcare services, then we have to look at the accessibility of services, the cost of care, and what is it doing to the out-of-pocket expenditure, and how does it help in the continuum of care. All of these, there are good examples from the region and from Nepal as well, which we will delve into in the next coming slides. So just a quick overview. So like I mentioned, in 1990s were the beginnings of telehealth interventions in the Southeast Asia region. In the 2000s, there were launch of various primarily donor-driven pilot initiatives. And in the 2010s, there were advanced stages of implementation, but to very little success. And whereas suddenly comes the pandemic and we saw huge growth because of the pandemic itself. Why did this happen? This was because of the disruption of routine health services, because health services was like repurposed for responding to the pandemic, and routine OPD services, routine care was suffering, and therefore telemedicine was a bridge to address that. Also, there was a need for massive scale-up of supportive services such as contact tracing, public communication, and even counseling and mental health counseling that needed to be, and for psychosocial support. And these were all easily deployable through a telehealth platform approach, and therefore it has been extremely successful during the pandemic. I will, in the interest of time, I will just quickly move on to what the region looked like from a pre-pandemic and during pandemic scenario. So we looked at it from, was there a national e-health strategy in place? So several countries in the region, including Nepal, had a national e-health strategy, and there was a regulation to govern the coverage of telehealth. This was there in Indonesia and Sri Lanka, and active promotion of telehealth modality by government and public health infrastructure was there in Sri Lanka. During the pandemic, many countries, as you can see on this slide, rapidly ensured that the coverage of telehealth regulation through the guidelines like the previous speaker mentioned were introduced by several countries. And also active promotion or engaging of both private sector and public sector telehealth players into the public health delivery system also were embedded during the pandemic. Again, this is a busy slide, but I will just try to highlight what are the key components where telehealth can play a role in from a health system strengthening and primary care supportive. So early screening and referral support. There are multiple modalities in which this is being done in the region. Health workers training, behavioral change interventions, specialized services, diagnosis, treatment, and particularly in rural and remote areas. And continuity of care, like I mentioned earlier, is a domain that we could look at from how telehealth could be a lever to strengthen our primary care services and the continuum of care. So there were various modalities like simple audio-based telehealth providers were there, then both audio and video like eSanjeevani, HelloDoc, and MyDoc. And then in many of our contexts, there was an assisted telemedicine model that was there. For example, in India, Glocal, and in various other countries in the region, this assisted telemedicine seemed to be a modality that were taking up very well in the region, probably because of the digital illiteracy of many of our populations in this area, and also the need for that assistive decision making in our region. I'll just quickly go on to give you an overview of what different countries in the region have been doing. This is again a very busy slide, but India actually is leveraging telehealth for supporting its national digital health mission, as well as its ambitious Ayushman Bharat, which wants to give universal health coverage to its population. So 150,000 health and wellness centers have been established across the country. And at the core of this is a community health officer who has access to specialists across the entire country, who is available to provide telemedicine consults and continuity of care through the eSanjeevani platform. Bhutan has a robust national e-health strategy, and they have been leveraging telemedicine, particularly because of their geography and its remoteness of many of its citizens to meet its public health objectives. And Sri Lanka has been investing into comprehensive national digital health framework, leveraging telehealth services with a focus on streamlining healthcare data sharing and population level interventions. So from these three countries that we just mentioned about, there seems to be an important role that a national digital health architecture, a national digital health roadmap, and supportive legal frameworks being in place for telemedicine to be implemented, scaled, and sustained. I want to just focus a little bit on this slide, which is because this relates to Nepal. Nepal has piloted several telehealth projects. However, there are several opportunities for scaling the existing as well as upcoming telehealth interventions for strengthening PHC with an aim to achieve universal health coverage through an ecosystem approach. What do we mean by an ecosystem approach? It is that telemedicine needs to be seen, or telehealth needs to be seen as an integral component of the health delivery system. It is not just an add-on just to make the connection between a remote patient and a doctor, but it should be an integral component, which means that it needs to figure in our line item budget. It needs to be considered part of the investment in our budgets as a health service delivery tool and mechanism. And it's fortunate to know that in May 2020, the Nepal Medical Council has launched the telemedicine guidelines, and that has helped the scale up of telemedicine during the pandemic. There are several opportunities, like I mentioned, to ensure that this kind of becomes embedded from the ecosystem approach. And we look at that in the next coming slides. So like I mentioned, if you look at the analysis from the region, there are several challenges that are in front of us, but these are also immense opportunities given what we have seen during the pandemic. So on the policy level, there is still quite a bit of ambiguousness on the regulatory guidelines. We still don't have good mechanisms on the reimbursement. How will telemedicine or telehealth be paid for? And there is no real mechanism in place in most of our countries for accreditation and licensing of healthcare provider. Because when telemedicine or telehealth gives scale, if you're doing something wrong, the scale also enhances the harm at scale. Therefore, there is a need for having mechanisms for accreditation as well as of licensing of telehealth provider. A doctor cannot go out and just practice on their own. They have to pass the exam, they have to have a license. But today, telemedicine providers can practice with no assurance of quality because there is no regulatory framework for that. So there are several of the policy interventions that need to be taken care of. On the technological side, there are a number of challenges, which again are huge opportunities. So today we don't have frameworks for data security. We do not really dwell upon privacy standards, and interoperability is still yet a challenge. And our user experience for telehealth has been limited. There are lots of tools, like the previous speakers mentioned. Artificial intelligence, machine learning provides immense opportunities for actually generating a case report and a longitudinal health record just from the conversation using natural language processing. These are all opportunities that are just knocking on our doors, and I think we should just leverage them. And at the organizational level, there is lack of consensus on telehealth standards. While the telehealth standards were made in response to the pandemic, most countries in the region would need a little more focused work on standards that bring together different stakeholders and address all of the challenges as well as opportunities that are coming and leverage this. And we really need to build in incentives for provider. Nobody is in this for charity. We need to look at how can we look at return on investment for the people who are investing in this, people who are building technology, and people who are developing these platforms, as well as people who are going to be providing these services. There are more challenges, but I'll just move on in the interest of time. So in summary, telehealth has been at the forefront of COVID-19 response. Sustained adoption for strengthening health services delivery really needs a strategic roadmap. And together, many countries in the region, if we come together and work together, we will be able to do this. There is definitely an opportunity for telehealth and telemedicine solutions to enable the continuum of care, including
Thank
the
you, Dr.
longitudinal.
John.
Thank you.
Thank you very much, Dr. John. It was really enlightening.
Thank you.
So,
Thank you. Sorry that I've run out
you
of
have
time.
shown us that there are opportunities. There's just a fear that the rituals sometimes hijack dharma. That is the problem.
Yeah, thank you.
Now, while waiting for Dr. Anil Sawal, is he here yet, Dr. Anil Sawal? No, not yet. So while waiting for Dr. Anil Sawal, who is supposed to give us virtual presentation, I request Dr. Prakash Paudel, if you are ready. Dr. Prakash is at the Global Telemedicine Center in Nepal. He is very active nationally and internationally. We were just talking about the experiences in California. So, Dr. Prakash.
Thank you. Can you hear me clearly? Thank you. Thank you, sir. So today, myself, Dr. Prakash Podal, I'm a physician, pulmonologist, and taking care of critical care patients at Nepal National Hospital. Today, I'm presenting on what we are actually doing as a global telemedicine center in Nepal National Hospital, and we have been doing a lot of activities through global telemedicine. So I'm trying to keep it very simple, and we'll be talking like what we are actually doing. So Global Telemedicine Center was established at the premises of Nepal National Hospital on 8th November 2019 with Professor James K. Good being the valued guest from California, USA. And I was very enthusiastic about Dr. Good because at the age of 78, he was taking care of almost 50 ICU patients through telemedicine, and he was working as a nocturnal critical care physician. So, and he was doing a lot of activities in telemedicine. So I was very impressed by him. So our background was one fine day, 6 enthusiast doctors from 6 different institutes all over Nepal came together to do something good in the field of telemedicine. So the institutes involved were Nepal National Hospital, Sahid Gangalal National Heart Center, Bhaktapur Cancer Hospital, IOM Maharajganj, Karnali Academy of Health Sciences, and Kathmandu Model Hospital. So doctors from these hospitals, we got together and we were planning something to do in the field of telemedicine. And I can see Pradeep Vaidya sir, he was also part of this. So with the global grant of Rotary International and support of global telemedicine, we got trained in San Francisco Bay Area. And after returning to Nepal, we decided to develop telemedicine in the respective institutes where we belong. And Nepal National Hospital is the center of all 6 institutes, which we developed as the Global Telemedicine Center. Later on, we added one more center, that is Mugling Highway Hospital. So altogether, we are now working on 7 different hospitals, and the to and fro of information of all these centers, Nepal National Hospital is acting as a center of this. So Global Telemedicine Center at Nepal National Hospital has been catering for a huge number of patients from inside and outside of the valley. And this service, as it has been a center of all these centers, so this service has been made easier by its dedicated toll-free hotline number 1174. So we developed this hotline number during COVID-19, and through this hotline number, we could get a lot number of patients calls regarding COVID cases and other issues also. So we took a lot of cases during that time. It has slacked a bit, but we are still working on it. So during COVID-19, this hotline number was instrumental in providing patient consultation as well as treating patients through telemedicine. It's a basic system, like we have developed a telemedicine consultation room, and these are the common devices used in telemedicine. And one interesting device which we have been using in telemedicine is Kubi. It's a telepresence robot, and when attached with a iPad or any kind of smart phones, then it enables practitioners to connect and engage with patients in many different telehealth settings, such as inpatient and outpatient visits, rural clinics, or any location where care is being provided. And I used it a lot during COVID times in my ICU, and during COVID. So since multiple rounds were not possible, so I use this, and every activity can be assessed through my mobile phone. So it made me very easy. So Kubi, when it is integrated with Zoom, it provides a special in-app feature through which Kubi can be remotely accessed and controlled, which enables better interaction with patients. And Kubi's pan and tilt moment personalizes telehealth for the patient and provides practitioners with the ability to engage and connect with both patient and on-site caregiver. So we can directly talk with the patient and we can, without any assistance from anyone. So it is easy to connect with the patient, so whether patient is in the ICU or patient might be in the remote place. So it helps both way, to the patient side as well as the caregiver side. So tele-ICU and telesepsis, Nepal National Hospital has developed a tele-ICU system for which we have placed PTZ camera in our critical care department with central monitoring system and telepresence robot Kubi. From the central monitoring station, vital monitorings of the patient along with communication with the live feed of the patients. We are doing this and it's an ongoing process. So after seeing these things of EICU, this concept of EICU, I didn't know anything about EICU, but after visiting in USA, I saw EICU, and after returning back to Nepal and me myself being a critical care expert, I wanted to reach more of the patients, critical patients to the remote places and in remote hospitals. So we are planning to develop some local system through which we could connect to the patients in remote hospitals. So in this regard, Nepal National Hospital, in collaboration with Global Telemedicine, have developed an intra-hospital networking system through which we could integrate monitors from different hospitals through a remote central monitoring station. 3 ICUs at different locations, that is Nepal National Hospital, Kalanki, Yeti Hospital, Bafal, and Nepal National Hospital, Nuwakot, could be integrated through this system. So we developed this system locally and we tested on that. And I think we did some good job. We tried a lot. We worked almost 1.5 months to develop the system. For this, broadband internet with 10 Mbps speed is being used at the central location for real-time updates. So objective was to monitor the data from medical equipment in a centralized manner, to monitor CCTV audio video in a centralized manner, to centralize the transfer of data between separate organizational entities. So the proof of concept was possible with the installation at the primary location. Primary location was Nepal National Hospital, and secondary location was primary location at Kalanki, and secondary location was at Bafal 1 hospital, AT Hospital in Bafal, and 1 hospital at Nuwakot. So for this, we placed a stable internet connection, backup connection if needed. Public IP was used, high-end firewall devices, properly configured for the scenario, and intranet. So we use this, and at the secondary location, stable internet connection, firewall device, and intranet. In the secondary location, the firewall device, strong firewall device was not required, but a very strong firewall device was used at the primary location. So it is a brief model of what we did and what we are doing. Like in you can see in the picture at Nepal National Hospital CMS server, we have placed a server and a MBR server at a central monitoring station, and we have connected monitors, patient monitors in different departments. We have placed 6 monitors in ICU, 6 monitors in neonatal ICU, and we have installed PTZ camera in these departments. And through firewall, we could encrypt it. We made an encrypted tunnel, and we could connect the monitors of different hospitals from this station, and all the data were present in the live condition. So, and even the blood pressure monitoring and even the inflation of the cough was possible with this system. So constraint was broadband internet service at remote location is one of the major constraints, and we are still working to develop a device which can actually work on all kind of monitors and even extract real-time data from the ventilator monitors. So in this regard, we used the same monitors. We used Mindray monitors in all the remote locations, and so it was possible, but we are still trying to develop a system through which we can connect every kind of monitors in every kind of hospitals. So that would be easier for us. And the use of different HMIS in different hospitals will be a current setback, as we can transfer real-time radiology and pathology data and images between two hospitals. So other activities of Global Telemedicine Center include, since we are in a global network of telemedicine, we have been conducting weekly global grand rounds where we have been discussing all kinds of remarkable medical cases from all around the world, followed by question and answer sessions. And every session is accredited and CME points are provided, which are funded by Global Telemedicine. So different training and seminars is an ongoing process. We have conducted a lot of training sessions for paramedics and school children about telemedicine, and as well as we have been conducting different training and webinars through telemedicine. I think the 9 and 10 class has this one chapter on telemedicine, and they, many of the students nearby our hospital come to get trained about telemedicine in our center. This is a brief. This project was featured in Rotary International Convention as one of the fine project that was ongoing during the COVID times, and I was even featured in one of the renowned international magazine. So this is one of the picture where policy formulation of telemedicine, and I had presented there, and we have been using. We did a lot of calls during COVID, and it was all free, and it was possible through a toll-free hotline number. And conclusion would be, without proper demand, appropriate licensure requirements, fair reimbursement, and supportive regulations, the full benefits of telemedicine will struggle to be fully realized. Telemedicine should be utilized to support and strengthen existing doctor-patient relationship, not to supplant them. And Global Telemedicine endeavors to enhance and strengthen the quality of care provided through telemedicine. Thank you so much.
Thank you, Dr. Prakash. You completed your presentation in time, and he explained how Nepal National Hospital initiated to form Global Telemedicine Center in Nepal. And this is time, not only time, this is smart time. Now we have ICU, not only ICU, smart eICU. So let's see how this eICU works in Nepal. Now, thank you, Dr. Prakash. Now we are going to join with Dr. Sanjay Yadav virtually. He is going to talk about experience sharing in mental health management through telemedicine. And Dr. Sanjay Yadav is a faculty member in the Department of Psychiatry and Behavioral Health at Penn State Health in the United States. He is also involved in the development of an integrated mental health service delivery program in Nepal. And I would like to call upon Dr. Sanjay Yadav for his presentation.
Just making sure, is my slides visible? All right. So thank you so much. I feel very fortunate to be a participant here, and just saw an impressive line of several works in South Asia. So this is mostly my objective for this presentation is to show how we're doing a usual mental health work in the United States. It has been a humbling experience. I think before COVID, I almost did not know that telehealth or telemental health was utilized in different parts of America. So this is, and also to touch upon with my work in mental health in Nepal, how this might be more, can be associated as something for a future work. So what changed, and we're going back to this 18th March 2020, exactly 3 years for today. So most of our organizations in United States got a similar email, and this is one of the emails that I'm paraphrasing here, that transferred the care delivery overnight. So this email read in a similar line, like, colleagues, a long email, but please read before progressing. And we wanted to roll this out to you as quickly as possible. And followings were several tips and how the processes were built up. And within a day or two, from almost working in person with most of the patients, inpatient as well as outpatient, we suddenly had a rollout of telehealth, including telemental health. And that was very amazing as I reflect on how things transformed overnight. So as telemental health, and the purpose for this particular presentation is how telemental health would be slightly different. That but mostly similar, which is the use of telecommunications or video conferencing technology for particularly mental health services. It has been used in all variety of settings, including community mental health centers, and then prison or correctional facilities, as well as nursing homes, while mostly catered in outpatient care as well as inpatient hospitals. Telemental health uses very similar styles and technologies, such as synchronous and asynchronous services that you see in most of the non-telemental health works as well. So what happened? And this particular figure tries to highlight that mostly for almost a decade, the health use in the United States was about 1% or slightly even lesser. And you can see this huge bump that happened almost overnight. And in the first 2-3 months of the initial wave, we saw almost, particularly mental health, being part of 40% of all outpatient care. And that was definitely, while increased the access, it is also very impressive to see that rest of the healthcare, besides mental health, were in the range of 11%. And over just as the first wave was tapering off, we could see that some of the bump actually tapered off, and you can see that the rest of the outpatient care dropped from 11% to 5%, while mental health persisted. And that was partly because of the modality of care that mental health had access, and that still is going on very persistingly on quite a significant, considerable percentage. So right now in the market, there are several different platforms, but these have been the leaders like Teladoc and Amwell. In our organization in particular, where I work, Penset Health, we've been using Amwell. And as you can see, telemental health now certainly has so many accessible features, as well as how several different innovative technologies have caught on. But in the landscape of the United States, it seems like the growth has slightly tapered, mostly in this past year. And then there was, again, another bump in 2022 earlier on, and while it has really now been plateaued. So, but it has also seen like almost several hundreds of startup companies, and they are in a very competitive market, while there are few very much like leaders, which are still holding like majority of the market. So I go back to some of the studies. As I read this, I think it was really good for me personally, just because I'm pregnant, and then having a young toddler already, it was good to just be able to use a speaker over the phone or Zoom, having multiple options rather than rushing around and trying to care for my baby, and then having to worry about leaving the house late and things like that. So definitely a sort of difference, as you can see, Western versus Eastern world setting. But these are very important in a daily US life, that this transformed and made accessible for a lot of mental health care. As there is no one size fit, and that holds true for mental health as well. What we have seen where the advantages have been similarly with remote settings, or where people have looked for more convenience, especially when it comes to childcare or flexibility, and people with more severe disabilities, and particularly in mental health care, such as people who have more anxiety disorders, have utilized this much more often. Well, there's exclusion, and that again, there's a lot of effort to make this inclusive. We see that people with most severe psychiatric condition, or people who have lesser access, or people who have been digitally divided, have faced and suffered exclusion in mental health as well. So largely, again, equity holds, and that we're always trying to make things equitable. America suffers in a very similar way, although the internet penetration is more than 90%. It suffers in a very similar way, that the poor people, the more disadvantaged, the more vulnerable, also have further access now the digital divide. And again, similar recommendations of improving, consolidating, expanding the broadband have been made over, especially over the COVID-19 years. And there were several programs which boosted this, but we still see that there's a lot of divide which exists. So the success story, as we're highlighting, really has been that compared to the rest of the telehealth or telemedicine service, telemental health has been very much widely received. Is particularly helpful for conditions such as OCD, social anxiety, and a variety of other conditions. But these are the ones that have seen, like, people have been drawn out of their houses and then be able to have the access to the psychiatric providers. And certainly in terms of reducing stigma, how the mental health care facilities can be stigmatizing. This has been a great relief to be able to use telemental health. So these challenges, again, it's fairly universal, but what we have seen is to really provide a very most high quality mental health assessment. Telemental health falls short in several situations. It also does not or cannot easily overtake barriers such as, when it comes to doing a physical assessment. And there are several mental health conditions as well as medications that requires physical signs evaluation, and which is not possible through telemental health. Ethics, and again, this is much more upheld as the regulations are expected to be carried out, but this when it comes to ethical considerations, we see that the challenges comes like, how do you make consenting much more easy, or consenting in a proper way? There are several practice regulations which keep changing, and they are hard to keep up with, and those things becomes very much harder when it comes to telemental health. The HIPAA, which is the Health Insurance Portable Affordability Act, which actually tries uphold the protection of health information, and that becomes issue, especially when it comes to like telemental health. And we've made a lot of advancement in protecting this, but we see that that becomes always a challenging thing. And then there are several crossing boundaries that can happen. In particular, when we are doing the services in the personal homes from both the end, from the provider end as well as the service receiver end, and those remain as a challenge. So I was going to show like the usual workflow in terms of mental health, and this is not much different, but just at the advancement, they're much more regular in America. And I thought this simple workflow is worth showing, and that's why I'm presenting here. So the first thing in most of this process becomes the enrollment of the provider itself in telemedicine or telehealth. And similarly, patient requires enrollment, which is several security checking as well as identification, verification process. But the scheduling of patients I've seen that it has really improved over the last several months. And as you can see, a variety of ways like patients would be placed on the scheduling, and there would be a mixture of hybrid type of models, like some utilizing telephone, and while others are coming there for in-person visits, while the rest could be on video visits. These are all testing environment pictures, and none of them are actually real actual patients. But you can see how the next step of scheduling happens, where again a lot of data are verified. And this slide, where the physicians or the nurse practitioners or one of the providers initiates this as an invitation to the patient, so that time, and then there you go to the next step of starting the visit. So they're also given the choices of having them contacted by email or phone, and then there's a time real time gap where both the patients as well as provider can have some time to preview where they are. Then comes the process of informed consent, which is very important. And particularly it is determined that especially name, age, and date of birth is verified before any of these visits actually take place. Similarly, clinical encounter, again, they can vary, especially in mental health. An initial visit goes along up to a length of 1.5 hours, but the follow-up visits are anywhere from 20 minutes to 30 minutes. And so again, those are the processes of intimate interaction and several different forms of evaluation. The side-by-side documentation can happen as well, but as we see that, those documentation, if you're doing engaging in patient interaction can be hindrance. But nowadays, again, most of the platforms have made things very easy to document and as you know, psychiatric documentation tends to be longer. Then comes several different things like how you're billing, coding, for falling under the licensor, and then there are several issues as well of as of how insurance are reimbursed. And there are regulations that makes you, again, be under the site of practice agreement. And each of these devices have to be HIPAA compliant as well. So I'm going to end this with another statement from the qualitative study. The clinic is a bit far from my house, and I was working during the period, so it's a bit far for me to spend 2 hours on public transport. And as you can see, this matters a lot for in any labor class of American system, and where telemental health has really made things easier. So future direction wise, again, we're trying to figure out how hybrid models would be much more feasible, when to use appropriately several different apps and digital therapeutics, even in mental health. There are a lot of work still to be done in how to make better reimbursement. And there are still restrictions how, as a provider, you cannot practice across US state lines. So those things are tending to be more relaxed as we have seen the utility of telemental health. And this is to show that we're what is called payment parity. So COVID actually laxed for the reimbursement to occur, as opposed to prior to COVID, all telemental health services were not paid equally.
Thank you, Dr. Sanjay.
So right now, yeah, we're almost like 21 states have already gone to payment parity. And this is to conclude that it has really helped with expansion. And I think, again, there's a lot of value and scope to do similar things in Nepal. Thank you.
Thank you. Thank you, Dr. Sanjay. Your presentation shows what is doable and at the same time what needs to be corrected. Thank you so much. Now, Dr. Pramendra Prasad Gupta is here, right? He's going to tell us about the journey of BPKIHS towards digital health. He's associate professor in the Department of General Practice and Emergency Medicine and does a lot of things like being medical coordinator, e-health and telemedicine program in BP Koirala Institute of Health Sciences. He also chairs ONCA Working Party on e-health GD Hub, Nepal. Dr. Pramendra.
Thank you, sir. Good morning, everybody. And thank you, Dr. Uday, for inviting me and getting me opportunity to deliver a speak on this wonderful symposium. So BPKIHS is an academic medical institute. So I'm going to tell you what we have done in digital health so far, with the objective of to demonstrate the feasibility of deploying distance CME and tele-expertise in district hospital in Eastern Nepal and link them to a tertiary care center to produce quality detective contents for distance CME adapted to the needs of practice in district level hospitals, and to organize a tele-expertise service at BPKIHS able to respond to the expertise request from distant hospital in the region.
to involve healthcare authorities and decision makers, disseminate lessons learned, and implement a plan for sustainability and scale up, to evaluate the impact on healthcare process and care outcome of a distance CME and tele-expertise network. With those objectives, in 2014, we started e-learning. Like we have in BPKSS, with the Ministry of Government, we have 5 or 6 healthcare centers, the district hospitals, which are joined with BPKSS. We send our interns to work over there. So we started e-learning with all those centers, in all those 5 centers, once a week, where all the consultants from different departments deliver updated topic which are used in primary level care. The challenges was inadequate technical facilities, with a lack of electricity and internet, and rugged geographical distribution, which make transportation difficult in hilly and mountain region. Shortage of skilled workforce and supportive policies were also notable challenges documented. Meanwhile, major opportunities were education and training of the students and health practitioners and increasing awareness among the general population. With all those challenges, we started in 2015 the telemedicine, and 2014 the e-learning. E-learning were in all those district hospitals in Dhankota, Ilam, Sira, Gaigat, and Bhadrapur. So this is the website of our BPKSS, where we put all the CME lectures which was delivered during the e-learning session. In 2015, we started telemedicine. The selection of deploying tele-expert center considering geographical limitations and sustainability of the project was the main focus for selecting the survey site. And the site which was selected were Hikal PSC, it was Patle Community Healthcare Center, Parewadin PSC, Dara Bazar PSC, Belka PSC Rampur, and Pauli PSC Bhojpur. So these were the center where we run the telemedicine. But since COVID, it was held because government was already started the isolation center where all the healthcare facilitators were pulled up in their isolation center. But now we have again started and we are planning to extend our telemedicine center in 100 healthcare center in eastern part of Nepal. So these are the total number of patients which we've seen in the telemedicine during 2014 to 2019. So these are the number of percentage of a patient in different district hospitals. These are the referred patients which are referred from different district hospital to BPKHS, like for operation, for investigation, further investigation, even for the specialized services. And this, the 12.1% was lost. We didn't follow up where that patient gone in BPKHS. The benefits, it was like the time saving, cost beneficial, direct contact with consultant, not have to sit in long queue, useful in counseling, effective in screening and health education. Where there were barriers and challenges also. The barriers were with internet failure, difficulties in audio visual, concerns about privacy, hesitation in adapting new technology, and lack of technical expertise. So to bear up these challenges, we train all the healthcare providers in a district hospital. In every 6 months, we do a training to them. We provide training to them. And then we also share all our telemedicine guidelines and our structure operative procedure for telemedicine with those, how we can operate telemedicine in those district hospitals. So there were lack of supporting environment also. It takes several weeks or even months to maintain the equipment and software if they stop functioning in the district hospitals because they are far away in the district, in the hilly regions, in the mountains. So we have to send our technician from Dharan there. But nowadays it has been already been, the issue has been solved. There are local technicians who goes over there and solve the problem. Health workers try to avoid the responsibility due to the lack of confidence, knowledge, and skill to use the available technology in delivery of health services. Lack of governmental coordination has also affected overall management of the rural telemedicine program due to the unstable political situation and frequent change of government. The policy related with the healthcare delivery system is fragile in Nepal. So these are the challenges like counseling to patient, because it was very hard to counsel the patient to consult through telemedicine, using telemedicine software and technical acquisition, clinical examination, basic surgical procedures, selection of patients, funding and sustainability, and low resource and underdeveloped infrastructures. We have also helped Bhutani refugee camp to start telemedicine in the refugee camp. They have got health post, then they refer the patient to AMDA for secondary care center and then BPKSF for tertiary care. So we started telemedicine from the health first to primary healthcare level. And these are the results where the referrals were decreased and the budget that was fixed for the referrals was also decreased after implementing the telemedicine program. So these are the paper which already been published from BPKSS. During the COVID, we started tele-OPD because in the first lockdown, all the hospitals were shut. So we started tele-OPD where all the department will make a schedule, a fixed schedule to come up in a tele-OPD services. These were the patient portal where patient can fill their form and then it goes to our system department wise and every department will come and see the patient via telemedicine. So these were the number of patients which were shown in tele-OPD. It was more than 10,000 patients we saw during the first lockdown. These are the percentage, department-wise percentage. And these were the follow-up patient in tele-OPD services. In second lockdown, we started teleconsultation program for the COVID-19 patients who were in home isolation. So we take a record from the municipal government, like municipality, and then we have put in 2 staff nurses with us who calls every and each patient and then asks regarding the requirement. So if they need any medical services, psychiatric counseling or dietitian counseling, we provide them. So these are the data, gender-wise data of that teleconsultation. So benefits of telemedicine in medical college will be to improve the transition of care for discharged patients from clinic to home settings, telemedicine in medical education, clinical training for undergraduates, which we are already been doing. Well, undergraduates are sent to district hospital for a clinical training where we discuss the cases via telemedicine. Pre-surgical evaluation can be done via telemedicine, and telehealth can also be utilized as an excellent tool for trainees as well as increased participation of educational programs in the community. So there was the GPMER and BIMSTEC telemedicine network for all the medical institutes. So it with the aim of knowledge sharing among member countries of BIMSTEC, promote standards and quality control in surgery by sharing operating videos, to initiate evidence-based guidelines for the common disease condition in the BIMSTEC region, use of teleconsultation to assess medical treatment in landlocked countries and small island states, preservation of traditional medicine knowledge, document and manuscript by digitalization, and to promote mobile health program in BIMSTEC countries. So these are the hospitals of Nepal and other regions who are joined in BIMSTEC countries telemedicine network. Then we done Nepal first digital healthcare ecosystem mapping. There is a Telementum app which you can download from Android and us users also. So we did ecosystem mapping where we tried to collect all the data of the leaders of the digital health who are working in Nepal, the organization, institute, even a person who are being involved in this ecosystem mapping. So we tried our hard to collect all the data, but there are still some organizations and people who are being missed. So I'll leave my email ID so you can contact me so we can update that in our app. So this was the workshop that was done during the mapping program. We did Nepal's first digital health hackathon, where the student of engineering college and the health participate in that hackathon, where they develop a medical app which can be used for a digital health in Nepal. So this was the runner of the digital hackathon. Even we did our Nepal's first digital health conference, which was on 28-29 November 2022. And I'll thank all of the people who were present in that conference to make that conference a success. And I'll thank Nick Simon Institute, WHO, Nepal Telecom Authorities, Subisu, and University of Geneva, who were the main supporter of our program. And this was a training session which was done before starting telemedicine in rural health. So this was a telemedicine services done during the COVID lockdown services. So thank you. That was my experience for doing telemedicine and digital from BPKSS, and we are trying to extend our telemedicine services in eastern part of Nepal. So in this, from 2020 to December, we are trying to connect more than 100 healthcare centers of eastern Nepal with BPKSS for telemedicine services. Thank you.
Thank you, Dr. Parmendra. We are a little bit late in time. which is allocated till 10:20. And still we have 2 more presentation, both are virtual. And Dr. Parmendra did very marvelous job through BP Kerala Institute of Health Science. And he is one of the passionate person in digital health. Thank you, Dr. Parmendra. Now I would like to request Dr. Miguel Tanimoto for his virtual presentation. He's going to talk about telemedicine experience in Mexico. He is a Vice Director of Ancillary and Diagnostic Service and Director of Telepresence, former outpatient gastroenterology clinic coordinator at the Gastroenterology Department in the National Institute of Medical Science and Nutrition, Salvador. Dr. Miguel Tanimoto.
It is a great honor for me to participate in this important telemedicine congress in Kathmandu, Nepal. I want to thank Dr. Udaya for his kind invitation to develop this topic. The title of my presentation is Telemedicine at the National Institute of Medical Sciences and Nutrition, Salvador Subirán. I have no financial conflicts of interest to disclosure concerning this presentation. This is my hospital, the National Institute of Medical Sciences and Nutrition, Salvador Subirán. We have 8 medical specialties, 16 subspecialty programs, 42 postgraduate fellowship programs, 13 medical schools attend for undergraduate courses, but we have only 221 beds. Our institution, below the medicine director, has 11 vice directions, and I'm the vice director of the ancillary and diagnostic services, as you can see in the image. This is the outpatient building in which we have more than 290,000 medical consultations every year. This is the new hospital building under construction. Before the pandemic, no one imagined or considered telemedicine present. Some even consider it is irrelevant and that it could never replace the traditional practice with physical contact with the patient. However, isolation due to the pandemic has led us to have an accelerated acceptance of the telemedicine globally. In an ideal world, research is financially supported. However, since the beginning of this telemedicine project, 6 years before the SARS-CoV-2 pandemic, we have not always had financial support for teleconferences, live demonstrations, consultations, case discussions with movie clips, or slides with high definition. Thanks to TEMDEC and CUDI, we have had IT and financial support at important venues in Mexico. Also, thanks to the technological infrastructure of TEMDEC and the network of Japanese friends who are key opinion leaders in endoscopy, we started self-financing using a laptop and a commercial internet line with reasonable and stable bandwidth that connected to TEMDEC infrastructure through the video platform. With a high-definition webcam and a microphone donated by TEMDEC with a mute button, they could see us and hear us. The laptop then projected the received images through a projector, and we listened the conferences with some commercial speakers. With the breakneck speed that technology continues to advance, as with artificial intelligence, cloud applications, and social networking, clinical case discussions, webinars, and teleconsultations, new horizons have opened for the telemedicine. Nowadays, with 5G networks and devices that are increasingly available in any computer store, it is possible to create and participate in international symposiums like the one we are at now can be held. In 2014, thanks to the support of TEMDEC and CUDI, we carry out the first live demonstration to our knowledge between two hospitals in Japan, Kyoto and Osaka, and the Mexican Digestive Disease Week in Cancun. These are some images of the 5 Japanese opinion leaders who participated in the discussion table and the giant screens that broadcast the cases live from Japanese hospitals with an auditorium full of Congress attendees. In 2018, also with the support of TEMDEC and CUDI, we successfully carried out the first telemedicine workshop in Mexico within the Mexican Digestive Disease Week in Mérida. Between 2014 and 2023, we have participated in 29 Latin endoscopy teleconferences, together with several Latin American countries. Again, in 2015, we carry out a live demonstration between hospitals in Japan and Korea with the Mexican Digestive Disease Week in Mazatlan. 6 years ago, we began a series of teleconferences with leading professors of opinion in endoscopy on the diagnosis and endoscopic treatment of early esophageal, stomach, and intestinal cancers. Throughout 2 years, between 2016 and 2018, there were 16 conferences of 1 hour each. These conferences were held with the sole purpose of being a non-profit educational resource for the training of the new generations of gastroenterology endoscopists in Latin America. Thanks to a generous donation from the Cisco company in the United States, the first telepresence room was built at our institution. This is the inaugural ceremony of the Telemedicine Center. Before the start of the pandemic in 2018, teleconferences between Japan and Mexico were held in this telepresence room. For several years, numerous papers on computer-aided diagnosis, big data, and artificial intelligence have been presented at international venues around the world. They represent challenges and new projects for our institution. These are some images of the stay sponsored by JICA and the Kyushu University for Nikkei doctors from Latin America. 2014, the beginning, and 2023, the present and the future of this project. Thank you for your kind attention.
Thank you so much, Dr. Tanimoto. Thank you so much. You were not only in time, but it was a very important information for all of us. You showed us the power of the global cooperation and everything. So do we still have time for Q&A, or shall we defer it? We are already delayed by more than 10 minutes. So maybe we have a tea break first. Dr. Tanimoto, would be very glad to meet you someday. We are in the same planet, okay? And there is a big cyberspace for us to meet anyway. Thank you so much. So in the presentation of the first session, we could see the huge potentials of telemedicine and e-health. At the same time, the power of cooperation and networking. Maybe indirectly, we also could see the impedances created by unwise, regulations and other things, in contrast to accelerating the speed of the progress in ICT. Thank you so much.
Now that will be the end of session 1. What a wonderful session. Thank you so much, chairs, and all of you speakers for your wonderful, great presentation. Now we'll have a tea break for about 15 minutes. Let's come back sharply after 15 minutes. Thank you.
Telemedicine. Here we have also the virtual presenter. I would like to introduce the chairperson of our session, second session, Dr. Arvind Joshi, consultant surgeon of BNB Hospital. Please be seated, sir. Give him a huge applause. Thank you very much. And we have another chair, Ms. Radhika Gimire. She is a matron of Kathmandu Model Hospital. Please be invited her. Thank you, ma'am. Likewise, we have another chair, Ms. Sumita Pathak. She is a campus chief of Kathmandu Model Hospital School of Nursing. Please be seated, ma'am. Thank you very much. I would like to invite Ms. Radhika Gimire for short remarks on the role of nurses in telemedicine.
Thank you very much. Thank you for the organizer team to give me opportunity to chair the session. Telehealth and nursing is very close words, not close words, close relationship. Medical science is failure without the nursing team. And we have seen in the pandemic COVID period, there was a big role of the nurses. And we are unconsciously, consciously, or formally or informally doing the telenursing. This is now the time about thinking the telenursing expansion in Nepal. I think the telenursing is not, it cannot be done in the simple settings. It is because of the license and nursing practitioners, there are the questions are big. That's why I would like to request our 3 nursing body in Nepal, Nursing Division of Nepal, Nursing Association of Nepal, and Nursing Council. These are 3 bodies to give the opportunity to expansion the telenursing. If we expand all over the country telenursing, we can give the critical care also in the remote area. And the nursing is the pinpoint. I usually said, nursing is the pinpoint. It has very much scope in education, caring, treatment, advising, counseling. Nowadays, there is a very big issues in the psychosocial counseling, school health. There as government has chance to give the school health nurse. And we can also expand in the telenursing in the school health program. School health program, there is a nurse, so that we can create our group, student health club, and we can give them counseling, lifestyle changing, challenging life, how to deal with. So that telenursing is now the time to operate. We are happy to hear that this symposiums is the theme is the role of the nurses in telemedicine. So we are so happy as a nursing professional, and Telemedicine Society of Nepal will emphasize and further work with our three bodies which mentioned before me. Thank you very much.
Thank you so much, ma'am. Ladies and gentlemen, it's my honor now to hand over this floor to the chair for the second session. Thank you.
Thank you. So we are here for the theme session of this whole symposium, Role of Nurses in Telemedicine. And without further delay, I would like to invite our first speaker. I think this is the remote presentation, Gandhi, Nepal, and the title is Provision of Healthcare in Remote Australia, Role and Responsibilities of Remote Area Nurses. Gandhi Pant.
Good morning to you all, and thank you, Dr. Zudai, for this opportunity to share my experience working with a remote area nurse. Remote area nurse in remote Australia. It's a really honor and pleasure to be here. As you can see, Australia is a huge country. Australia is a huge country. When we think of Australia, we basically think of Sydney, Melbourne, and Great Barrier Reef. But the interior of the country is extremely large. As you can see, Australia has a population of 26 million. Land mass is 7.88 million square kilometers. And it is the sixth largest country by mass, and 80% of people live just across that green area in the coastal region. And the interior of the country, as I said, is vast, arid, inhospitable, and empty, except the scattered settlements of indigenous people who have lived there for millennia. I have been working in Northern Territory. Northern Territory itself is quite huge. Population is only 230,000 people. Land area is 1.42 million square kilometers. 18% of Australian land mass. Darwin is the capital city with population of 150. The second largest is Alice Springs in the central of Australia with population of 30,000 people. North and south distance of Northern Territory is 1,600 kilometers, and east to west is 970 kilometer. This is one of the communities that I've worked, and all the pictures that I have presenting here today are taken by myself and with permission. Just a warning, there are some clinical pictures which are a little bit of gory, and but it's a reality that we have to deal as a nurses on a daily basis. This is the map of Northern Territory from the island communities and all the way down to the Central Australian communities. These are indigenous settlements. Population size is, there are 72 communities, as you can see, that are scattered all around. Population size of these communities can be anywhere from 100 to 3,000 people. Most of the communities are below 500. So, and the Northern Territory has the highest population of indigenous residents amongst its population. And as you can imagine, providing quality healthcare in this landscape and in this environment is quite challenging in many ways. Nearest hospital can be anywhere from a few hundred kilometers to 1,000 kilometers. Unfortunately, indigenous health is quite challenging. They have the worst of the both worlds. You have the scourge of communicable disease, primarily caused by poor nutrition, poor hygiene, cramped living conditions, and the harsh environment they live in. The temperature can be up to 50 degrees centigrade in summer times and very arid. And also now they have adapted the Western lifestyle, and they, as you can see, the 5-year from 2015 to 2019 data, the mortality rates by categories you can see, as it is explained there. So. We have a special category of nurses in remote area. They are called remote area nurses, and they are the backbone of nursing care and medical care, providing quality medical care to the indigenous communities. As you can see there, RANs we work independently. Sometimes we work alone. During the night times, we are on call and we deal with all the emergencies. The good thing for us is that it's a protocol driven and the help is only a phone call away. Telemedicine has been well advanced in Australia for the last 14 years that I have been working there as a freelance remote area nurse in different communities. As you can see the previous map that I have probably worked in all the communities that were scattered in that map of Northern Territory. We assess, treat, and evaluate care that is based on standard of treatment manuals and protocol manuals. And when those, and that is our scope of practice, we practice within the guidelines of those manuals. And when that practice of guidelines requires, then we communicate through medical retrieval and consultation center, which is called MRAC, by phone or video. And we have been doing this for a long time. All clinical data enter into PCI's patient care information system, which is remotely accessed by attending doctors. Some of our MRAC specialists actually working from Melbourne, working from Sydney, and some of them actually working from Europe and South Africa. They are all Australian certified and qualified, and they have to go through a lot of training as well. So standard of care is, these are our essential books. We practice within the guidelines. As you can see, CAPA, which is the Central Australian Rural Practitioners Association. It tells us all, allows us to prescribe certain antibiotics. It allows us to do certain procedures. And the Women's Business Manual, which is culturally appropriate for Indigenous women. And then we have the other reference manuals, which are the Central Australian Handbook of Injectable Drugs, Australian Medical Handbooks, and so on. So what are in order to provide a quality healthcare, you need to have a quality education, quality training, skilling, reskilling, and upskilling. We are quite proficient in stabilizing patients that come to us. And these are the basic criteria where you have to have in order to become a nurse. 4 years of postgraduate clinical nursing experience. They prefer you have their ICU and emergency. And in some cases, they will take you if you only have ICU experience. Have gone through an 18-month of transition program from RN to RAN. Remote emergency care, which has to be recertified every 2 years. Maternity emergency care has to be recertified every 2 years. Advanced cardiac life support and pediatric advanced life support every 2 years. One of the most important thing that we do is we actually dispense medications. So we are the pharmacy. So for that one, you have to have a pharmacotherapeutics for registered nurses, which is a certification from university. We also provide primary health care. That is our bread and butter. For that one, we have to do childhood vaccinations. So you have to have a certification understanding vaccine and national immunization program. And Australia has a very, very high rate of vaccination, up to 80–90%. So in terms of core competencies, you must be able to work independently as a remote area nurse. You have to be able to make a decision and escalate as required. Must be proficient in basic suturing skills, plastering skills, phlebotomy, urinary catheterizations, venous catheterizations, NG tube insertion, and must be able to have a computer skills. In addition to that, obviously, licensing is well controlled. Your nursing license is renewed every year. And the police criminal check will have to be also done every year, as well as working with children check which is just to ensure that you are okay to work with children. So that is also controlled by the police. And there are other many requirements on an annual basis. Continuous education is another part of it. So in order to renew your license, you have to have 50 hours of continuous education and sometimes more depending on your level of expertise. So this is one of the last community I work, as you can see how it is. Only 170 people live there. Nearest hospital is about 500 kilometers away. And this is, I worked there last month. This is a 2-nurse post, but unfortunately, because of the recruiting issue, I was alone there for 6 weeks with a non-clinical person, a driver as my support, and I was on call most of that time. That's another community in the Western Australia, right in the central. This is just a view of how the community looks like. This is one of the community called Ingawala. That's another community, the local people just enjoying a little bit of evening time with the fires. And then there's a kangaroo on the fire as well, as you can see. Just to warn you, as I said, some of the pictures are a little bit gory. So this is the central of Australia. I've worked close by here as well. And we are very close to Western Australia. This is absolutely arid and absolutely inhospitable climate. So what are the emergencies that we manage? Stab wounds, lacerations, and the head injuries. Unfortunately, there is a lot of mental health issues and substance abuse. So we deal with the successful suicide attempts, successful otherwise. Chest pain and the respiratory distress are actually taking a lot of our times as well. As you know, when there's a chest pain, you have to rule out the cardiac origin of it. And being in Australia, of course, we deal with envenomation, snake bites, spiders, scorpion, and up on the top end, box jellyfish, envenomation, irukandji as well. We also attend motor vehicle accidents. As you can see, unfortunately, roads, there are no traffic lights and no speed limits, and the roads are often dirt roads, so you can tip over very quickly and very easily, and it is not a good experience to deal with motor vehicle accidents. As a matter of fact, last year I had to deal with one, and it was not a good experience with some fatalities there, and I was the first on the site. We also deal with acute rheumatic fever because of the prevalence of skin problem, especially in impetigo. That is it's a developing country, poorer sub-Saharan country disease, but we deal with it.
Time limit.
Okay. Under 2 is febrile, as you can see, and acute alcohol intoxication and all that sort of issues there. So there are some of the clinical pictures, just be mindful. Infected scabies and abscesses, and as you can see again there, cellulitis developing in the last picture. Unaffected catch in both instances, and in the second picture was he came with the wound dressing, but he had a blood sugar of greater than 39.4, which is 628. These are some lacerations. This lady, alcohol intoxication required, I won't go through that video. That's what happens when you have a head injury. So we had to transfer through Royal Flying Doctors, which are always on standby for us, depending on the acuity. It is a huge problem with the dental, especially amongst the mental health client with the oral issues. A little bit extra that I do with the patient from time to time. And this is one of my patients that is very good painter. And as you can see, I'm having a little bit of time with the locals there. And this is also something quite interesting in the Australian community. And unfortunately, that little Joey didn't survive. His mother was killed on the road accident. So the people brought that to the clinic. And the boys are always boys, so they wanted to have a fun and caught a little bit of saltwater crocodile in the water hole and brought to show us. In the outbacks, sunsets are always out of this world, and the sunrise as well. And that is the presentation. And I also take care of the little bit dogs whenever I get opportunities in the communities. So there are a lot of feral dogs. So without the telemedicine, we wouldn't be able to survive working in remote communities, often alone and making decisions, and without the support of the other professionals on the other side of the phone and the video. And it really, really works well. And I hope we can all learn from Australian experience. Thank you for your time.
Thank you, Mr. Nepal, for enlightening us with the concept of remote area nurses.
We are really honored to have Dr. Mingmar Sherpa sir here. He's a telemedicine legend. And also Dr. Mahavir Pun, he was here. Yes, sir. So thank you. Yes, Mahavir sir. Thank you. Here are our seniors, our finalists, and thank you so much for being present here. Thank you.
Namaste. I would like to invite Kanchan Gautam as a second presenter. She is from MNCS FP Rural Healthcare, Nepal. He is presenting about telemedicine in primary healthcare center. Kanchan Gautam had completed her bachelor degree in nursing science and master degree in clinical psychology. She has been working in her remote areas for Nepal for quite some time. Currently, she is working as a technical officer for maternal, neonatal, child health and family planning in rural places of Nepal.
Okay, then this is your screen there. And
In the meantime, I would like to have some comments for Mr. Nepal. It's very interesting to know that there is a definite this term of remote area nurses is not very known in Nepal. So I think this whole concept of specialized remote area nurses could be very new for Nepal. I'm sure that you must be making Nepal very famous in Australia. Thank you very much for your presentation. So, Kanchan Gautam, you can start.
Namaste and a warm good morning to all of you. It is a matter of great pleasure and honor to be speaking in front of all the respected personalities present in this premise today. I'd like to especially thank Dr. Uday Koirala for giving me this opportunity to speak in front of everyone. And I'm thrilled to be in the 16th Asia Telemedicine Symposium. I'm Kanchan Gautam. I'm currently working in the maternal, neonatal, child health and family planning field. And as a part of my job, I train and educate the health service providers of various health facilities of rural areas in Nepal. As we all know, telemedicine is the system where the healthcare professional communicate electronically with the healthcare participants located anywhere in the world without having to physically visit them. Through telemedicine, the healthcare provider can examine, investigate, and manage a patient with both of them located in different places, and they can treat them through electronical devices and technology. Similarly, primary healthcare is an approach which addresses the broader determinants of health, which focuses on the comprehensive interrelated aspects of physical, mental, social health and well-being. It is the initial level of health facility with essential primary healthcare such as maternal, neonatal, child health, family planning, immunization, reproductive health services, first aid services, and so on. Every one of us
witnessed the usefulness of telemedicine in the times of COVID-19. The number of people taking online health services, including counseling, increased exponentially at that time. The engagement of telemedicine in primary healthcare level helps to bridge the urban and rural health divide. Having worked in the field of maternal neonatal child health based in rural part of Nepal, I have experienced various instances where a complicated delivery managed successfully by virtual mentoring provided by nursing staffs through the help of trainers. I recall this one time when a nursing staff of a primary healthcare center called us because she was skeptical about the management of eclampsia. So we mentored her and she was able to manage the case successfully and refer it to the higher center. Besides that, multiple cases of postpartum hemorrhage has also been managed through telemedicine, saving the lives of many women. Furthermore, I have witnessed the patients with mental illnesses getting better with regular online counseling session. With that, healthcare professionals are providing birth preparedness counseling, family planning counseling effectively through telephone, and in many cases, forcing complication has been prevented through a simple phone call consultation with the healthcare providers at the primary healthcare center. Having said that, there are still some challenges that comes along while providing healthcare facilities in the primary healthcare center through telemedicine. Firstly, the inaccessibility of internet services, electricity, proper network, lack of basic amenities like computers, router for internet, or a simple smartphone are some of the hindering factors. Second of all, the mindset of healthcare participants can play a major role. Because as far as I have experienced, the low literacy rate, language and cultural barrier in the people residing in rural areas of Nepal make them reluctant and rigid towards new technology while more inclined to the traditional health-seeking approach. So these aspects should be taken into consideration. It goes without saying that telemedicine is an enormous step in healthcare. Government and non-government bodies need to align their efforts towards sensitizing importance of telemedicine to the people, ensuring the accessibility of technology, basic amenities, and providing the healthcare professionals with basic training and incentive, especially in the underprivileged areas of Nepal. I firmly believe that this generation will get the bulk of our healthcare in the palm of our hand. With telemedicine, the future of healthcare system seems brighter and full of hope to me, and it has a long way to go. Thank you so much and have a great day ahead.
Thank you, Ms. Gautam, for sharing your experience about saving life with technology. And I would like to invite our next presenter, Professor Yoko Simpuku, and from Hiroshima University. Professor Simpuku is Vice President of International Public Relations and Professor of Global Health Nursing. So Professor Simpuku, his title seems very interesting. His title is Use of a Smartphone App in Telemedicine.
Thank you very much for the kind introduction. I'm Yoko Simpuku from Hiroshima University. I'm going to talk about use of smartphone app in telemedicine. And my field of research is Tanzania, and especially in maternal child health. And maternal health indicators of Tanzania includes Maternal mortality ratio is 556 over 100,000 live births, and births attended by skilled personnel in rural area is 55%, which means nearly half of women do not have any access to healthcare when they are giving birth. And if anything happened during delivery, it's going to be too late to save mothers and babies. So I developed an educational materials using midwifery point of view, which means to keep normality of mothers and babies and prevention of complications. Because if complication happens, it will require a lot of resources, including human resources. So it is better to prevent complications. And I use evidence from WHO guideline and local findings. Because if you use international global guidelines in the local area, it is sometimes difficult to understand what this means and how you can really implement the content of the guideline. So I use this expertise in local area and merge the global evidence. And I developed first I developed the picture story and we provided educations to mothers and their families in rural side and followed them up 1 year later. And we found that if they received education, they knew more health center or hospital in case of emergency, and they arranged someone to accompany her to go to health center or hospital for birth emergency. And woman decide her birthplace with family members. And they attended antenatal clinic more than 4 times. And in the end, there are less trouble like bleeding or seizures during labor and delivery. There are less cesarean section and there are less complications of newborns. So we found this education is somewhat meaningful and we want to expand this education to national level. And I was also finding some issues in the medical record in Tanzania, which is paper-based. This is like antenatal care and the labor record, and it's paper-based, which means it's easily broken or lost sometimes. So it's better, we are thinking it's better to make it online or records. Electronic record so that we can keep the record if you lost some piece of paper. So this is the idea of the app. This is called personal health record, and midwives can access to this record and also mothers can access to the record. And midwives can input the data of antenatal care and they save in the cloud. And mothers can access to their own records so that they can see what their condition is based on the antenatal care. And we also put educational materials into the app so that anyone can access to the educational materials, and which means that midwives used to provide education to each woman. It would take a lot of time to educate everyone one by one. But if the contents are already in the app and anyone can access, this can create the knowledge network and connection in the platform, and the workload of midwives can reduce. And this is how it looks in the app. It's called Taarifa za Mama in Swahili, which means mother's record. And if you go to the second page, you can see how many months you are and your expectant delivery day. And according to the gestational weeks, you can see the condition of the baby and pregnant woman. And if you go to the chart of yourself, you can see visually your weight and blood pressure. And if any abnormal data are available, you can see immediately. And you can see the more detailed data if you click it. By the way, it's all written in Swahili because it's the language used in their original local area. And this is the Mama's BBS, which means this is the social media. Mothers can ask or write anything to share the information. And midwives sometimes jump in the conversation if any information is not medically correct. And mothers can share the information like peer education. And this is how you can look to input the data into the app. Midwife is just touching the phone and she's checking edema of the pregnant woman, and they are saying, oh, there is no edema. So she can just put no into the app and it's already recorded. It's very simple and easy. Anyone can use it. And it's already available in the iPhone and Android as well. And in the social media, BBS, there are many comments they send. And if you look at the words they use, they wrote like go, give, midwives, mothers, and ask. And if you analyze the this data, how the words are connected, you can see mothers is asking midwife about their problem and asking if they should go to the hospital or not. So they use, as I said, they have limited access to antenatal care and delivery care, and they don't know, they are not sure when they go to the hospital. But in this app, they can ask directly to the midwife if they should go or not, which is quite useful to save the health condition of mothers and babies. And another interesting fact is that fathers who came to the antenatal care with their wives, they kept asking us to let them download the app. So it was meant to use for the mothers, but it's also useful for the fathers to learn about their condition of the wives and the babies. Then they can know how to take care of their own wives and babies. And currently, we are trying to develop the project with more electronic mobile devices, which is called ICTZ, which is a mobile fetal monitor, and it's created by a Japanese company called Melody International. And we collaborate together, and we also try to learn the mobile clinic and use this device and app together. Then app can be the network, the platform for sharing the information, and any doctors and midwives can access to the this fetal heart monitor record. Then they can say the baby is in a good condition or not, and if there is any bad condition of the baby, we can refer the mothers to the hospital. I hope this project can be helpful for mothers and babies because we used to focus on mothers and we had less information about babies. But now we can see more condition of the baby, and then we can save more mothers and baby together. So this is our current project, and we hope to see the effects of this project in the near future. Thank you very much for listening.
Thank you, Yuki. We have to learn about the very dedication to the health service from the remote area health workers. Thank you very much for your nice presentation. Now we would like to invite the Professor Fumihiko Yokota from Kyushu University. Fumihiko is presenting the mask wearing behavior among people who were unaware of their diabetic status or cross-sectional study during the first COVID-19 wave in Indonesia. Fumihiko, Professor Fumihiko, the floor is yours.
Hey, good afternoon. Namaste. My name is Fumihiko Yokota from Kyushu University, Fukuoka, Japan. I want to thank all the organizers, Moriyama Sensei, Kudo Sensei, all the Telemedicine staff, and all the Nepalian audience and staff for giving me this opportunity and make this conference happen. I would like to start my before my presentation, I would like to share 1 minute video which shows our telemedicine project at the Kyushu University called Portable Health Clinic. So can anyone see this video now? Is it shared?
Yes, yes.
Okay, thank you. I will start. This project called the Portable Health Clinic Telemedicine System started in 2012 at the Kyushu University in collaboration with Grameen Communication in Bangladesh. And the purpose is to increase the access of a basic health checkup screening to the rural area and to save lives and to save medical costs by detecting disease at the early stages. So basically, this portable device carried by the nurse outreach as an outreach service to the rural area. This portable box contains more than 20 medical device sensoring connected to the mobile phone and tablet. And the nurse will first goes to the outreach hotspot and doing the registrations using a barcode for each patient and do the health checkup, the blood test, BMI, blood pressures, and this is a glucose test kits and urine test as well. And the result will immediately screened and diagnosed these using screening device and categorized into 4 depending on the priority of the disease. And those who have orange or red color, which has some type of disease, will arranged by the nurse to access to doctor at the central level by telemedicine. So this is supported by the nurse and can get the e-prescriptions for them to get the drug nearby the hospital. Okay, so having said that, I would like to start my presentation because this presentation is based on this activity, telemedicine activities. The data is used. This is a mask-wearing behavior among people who are unaware of their diabetic status, cross-sectional study during the first COVID-19 wave in Indonesia. So this slide shows the conceptual framework of this research, and I'd like to explain about the objective and the research question and hypothesis, which basically we would like to find out the association between type 2 diabetic and mask-wearing behavior. So this after adjusting for these confounding factor, 6 confounding factor, which influence both diabetic conditions and mask-wearing behavior. Another objective is to find out the percentage of people in rural area who are not aware of their diabetic condition and who are newly found the diabetic condition after this health checkup. So the hypothesis is if they already know their diabetic condition, they are more likely to wear mask. However, if they are not aware or not known about diabetic status, they are less likely to wear the mask. That is a hypothesis to be tested in this. And mask wearing, these data are collected by the questionnaire and health checkup data. This one is health checkup data using the Easy Touch GCU. And mask wearing, we ask question, in the past 30 days, ever used mask? How often do you use mask outside the home? Always, often, sometimes, not, never. And we categorized into two, always or not always. And to test this hypothesis, we use the SPSS and chi-square test and the logistic regression test. And this data was collected at the 3 rural districts in the central Java in Indonesia called Yogyakarta suburbs. And 206 patients received this health checkup who are voluntarily recruited from the community residents. And this one was corrected. This activity was implemented during the first wave of COVID pandemic in Indonesia. This graph shows that the y-axis is a number of COVID positive patient, and the x-axis is the time. So this is the February to April in 2021 is a survey period. So this graph shows the data collection process, how the nurse played an important role in this data collection. As you can see, as you saw in the movie, nurse played an important role for registering the patient, asking the questions, and checking, conducting a health checkup and the data entry, and arranging for the doctor's consultation, patient, nurse to doctor telemedicine, and e-prescription printing, and the explanation, education, and the next appointment for follow-up, and the continuation of the follow-up. So this is a result showing that looking at the two factors, first one is, have you previous history of diabetes? They already know or not know. And this is this survey's result of the diabetes. So this red box showing that they didn't know before they are type 2 diabetes, but they newly found at this survey, at this health checkup, that they got blood glucose level is more than 226. So which means 74% of the rural people are not aware, not known about their diabetic condition. And this yellow part saying that they say, yes, they knew they are diabetic, but they still, their glucose is high. So which means they are not controlled. 70% are not under control. And the blue color box means they are aware and they are controlled. They are not, they didn't get 126 milligram or more blood glucose at this survey, at this blood test. This is another result that showing the relationship, association between newly found type 2 diabetic status and the mask wearing behavior. When you look at this red box color, 16% are not always wear mask among those who are type 2 diabetic this time, comparing to only 6.7% are not all answered, not always wear mask among non type 2 diabetic participant. So it means that if they newly know, they didn't know before, but they knew this time, they are more less likely to wear a mask. And this is another, this is looking at the history of diabetes. They already knew that they are diabetic, then they are more likely to wear mask and less likely to not always use mask. So this is the opposite result. So this is the final result that those who have diabetes, newly found diabetes, they are 3.8 times more likely to not always use mask. And if they are already they knew already they have a diabetic condition, then they are less likely to not always use mask, meaning they are more likely to use mask. So based on these results, it will be important to increase access to screening tests for those who are not aware, not known for the diabetic condition, and as a nurse role to educate rural community people for appropriate method to prevent from disease at the early stages for increasing mask wearing behavior for next pandemic. And thank you so much for all the listening. Dhanyavad.
Thank you, Professor Fumihiko, for your wonderful presentation. Now, we would like to invite Suruchi Khadka for presentation. She is presenting on revolutionizing home-based nursing care, the benefit and challenges of the integrative telemedicine, benefit, opportunities, challenges.
Your time will be 10 minutes only.
A very warm good morning. Namaste, everybody. I'm Suruchi Khadka. Today, I'm going to talk about revolutionizing home-based nursing care through telemedicine. I'll give a brief introduction. We'll talk about the benefits of integrating telemedicine in home-based nursing care, challenges of integrating telemedicine in home-based nursing care, and potential solution to overcoming challenges of telemedicine. In recent years, there has been a substantial change in the healthcare business toward home-based nursing care. With the introduction of telemedicine technology, patients can now obtain quality medical treatment from the comfort of their own homes, while healthcare practitioners can provide more efficient and cost-effective services. Talking about the benefits, There are lots of benefits of telemedicine in home-based nursing care. So the first one is increased access to quality care. One of the significant benefits of telemedicine in home-based nursing care is that it increases access to quality care for patients, especially those in remote or rural areas. Telemedicine enables healthcare providers to deliver high-quality medical care and consultation to patients and from a distance, overcoming geographical barriers. Improved patient outcomes. Telemedicine enables healthcare providers to monitor patient progress in real time, allowing them to intervene quickly when necessary. Talking about another benefits, we can say telemedicine helps in enhanced patient engagement. With telemedicine technology, patients can actively participate in their care by monitoring their health, communicating with healthcare providers, and accessing educational resources. This can lead to better patient engagement and empowerment, resulting in improved healthcare outcomes. Cost effectiveness. Telemedicine technology can significantly reduce healthcare costs by eliminating the need of patients to travel to healthcare facilities, reducing hospital readmissions and optimizing healthcare delivery. So now let's talk about the challenges. Technology barriers, security and privacy concerns, legal and regulatory challenges, integration with existing healthcare systems, reimbursement and funding challenges, resistance to change and lack of awareness are some of the challenges. Talking about technology barriers, one of the significant challenges of telemedicine in home-based nursing care is the lack of access to technology. Patients who do not have access to smartphones, computers, or high-speed internet may not be able to benefit from telemedicine services. Security and privacy concerns are also one of the challenges to apply telemedicine in home-based nursing care. Telemedicine involves the transmission of sensitive health information over the internet, which raises security and privacy concerns. Healthcare providers must implement strong security protocols to protect patient data from cyber threats. So, legal and regulatory challenges. Telemedicine is a subject to various legal and regulatory requirements, which can vary from state to state. Healthcare providers must ensure that they comply with all applicable laws and regulations to avoid legal and regulatory issues. The next one is integration with existing healthcare system. Telemedicine technology must be integrated with existing healthcare systems to ensure that patient data is properly captured and shared. This can be challenging due to differences in software and hardware platforms. Reimbursement and funding challenges. To support the implementation and maintenance of telemedicine programs, it tends to be costly. Resistance to change and lack of awareness. Hesitation due to lack of understanding or familiarity with the technology. It can be one of the biggest challenges in telemedicine. So some of the potential solutions can be needs assessment and goal setting, stakeholder engagement and collaboration, training for healthcare providers and patients, effective communication and documentation, can also be one of the greatest solution, continuous quality improvement and evaluation. Thank you very much. I would like to thank the organizer team and special thanks to Dr. Uday for providing me this opportunity. And thank you all. Thank you very much.
Thank you, Ms. Kharga, for letting us know about this new facet of nursing care, home-based nursing care. And now we'll move forward for the next presentation. Our next presenter is Dr. Prabhat Adhikari, and he'll be talking about tele-ICU care. And a brief introduction about Dr. Adhikari. Dr. Adhikari is MD in infectious disease and critical care. He's been practicing both in Nepal and USA, and he's been leading some research project, mostly in the field of infectious disease and ICU. Dr. Adhikari has established a medical IT company called Dafe Care. And Dr. Adhikari has been providing healthcare services to the underprivileged population of Nepal through the ASK Foundation, a non-for-profit organization. Dr. Adhikari, the floor is yours.
Good afternoon, namaste, everyone. And it's my pleasure and privilege to be here. And today I'll be talking about tele-ICU. So we'll be focusing more on the tele-ICU, the technical and the clinical aspects of it, and our experience in Nepal, and what's the future holds for tele-ICU globally. So I think I'm the last speaker, and then we have lunch. So let's please bear with me for the next 10 minutes. You come up. So, so the subtitles of today's presentation would be, we'll talk about the problem statement, especially in Nepal, and why there is need of tele-ICU. And then we'll talk about what is tele-ICU. Then we'll talk about impacts of tele-ICU and how to implement it. And then if we get some time, we'll also talk about our experience in Nepal and some telemedicine research we've been doing and what next in the world of telemedicine and tele-ICU. So let's start with the problem statement. So I'm going to go with the real cases that we've been dealing in tele-ICU. So this is a case from Nepal back in 2021. So there was a 55-year-old female. So I don't know, some of us are doctors, so we'll understand. But anyway, I'll try to simplify it. So there's a 55-year-old female who got COVID pneumonia, and she got a really bad complication. We call it ARDS. That's when your lungs are totally shut down. You can look at the picture. So if you have ARDS, it's really bad. You can put the patient on the ventilator, but it's very tricky because you have to manage the ventilator, you have to manage the other medications. So it's a lot of issues going on. The patient was already on shock and wasn't getting better, and they were of course having problem with extubation and taking care of the patient. That's when they reached out to us. That was a local hospital within Kathmandu Valley, and the hospital reached out to us for help. At that point, we're too much occupied. There was a lockdown, so it was not possible for all of us to, or some of us, to go to the hospital every day. So we went to the hospital for the first time, and then we set up tele-ICU kind of thing. And then onwards, we started taking care of the patient by tele-ICU in Nepal. And within 4 or 5 days, the patient got better and even got extubated, and that was all good. So the scenario with Nepal is that every 1,000 population in Nepal, there is only 0.8 doctor. I'm talking about general overall doctor. So there are only 30 plus critical care doctors all over Nepal, and most of them, or almost all of them, are centered in Kathmandu. So you can see that there's no critical care, proper critical care, I would say, outside of Nepal. So it's really bad, And if you talk about USA, I also work sometimes do tele-ICU to US. So there's another case in US. So that happened in 2019. So 35-year-old female, male in ICU with status asthmaticus and AFib with RVR, and the patient was on BiPAP, then maybe got acidotic. Intubated, was also on diltiazem drip, and soon after intubation, the patient quoted cardiac arrest, So they follow the proper ACLS treatment. That's a protocol, but they need help. So critical care doctor were there. So what happened is that this patient was given cardiogen. So for cardiogen, you need antidote. You need glucagon, right? So the patient wasn't getting glucagon, was getting all different meds of ACLS, and the patient isn't waking up, right? So what you need, you just give glucagon. You give 1 shot glucagon, the patient woke up next after the shot, So that's what you need. So 1 glucagon, the patient woke up, and the patient was later on extubated, walked fine. His mental status was good. So this is a few of the examples where saving life is important. And what you need is just the idea or just a discussion with the critical care doctor. So the critical care doctor shouldn't be there all the time, because you have other doctors who can take care of the ventilator. They can put lines, they can do a lot of things. But this kind of situations happen all the time, and you need somebody on your back, and that's tele-ICU. So what is tele-ICU? Let's go into details. So this is a really nice article from Frontiers review article in 2021. And especially after the pandemic, the telemedicine as such is booming, right? So telemedicine is a lot of things. So we discussed about telenursing, home isolation, telecare, so it starts from home to the outpatient, even in the ambulances, goes to the emergency department, goes to inpatient, goes to the ICU, and even goes to pathology labs, because you have telepathology, you have teleradiology, and you have all different specialties we have in medical sectors. You can do it telemedicine. So it's called telemedicine, tele-ICU, telepathology. So you can do everything tele, most of the things tele. So it goes with the cycle. So whenever there's an introduction of new technology, there's always denial. People are not used to it, so they will kind of deny or they refuse. There's hesitancy, there's reluctancy, and later on they see the benefits, and there's acceptance, and they start becoming advocates. So it takes time. So we are in the baby steps, right? So telemedicine has been introduced in Nepal, and one after another, we're taking baby steps. So ultimately, we'll get there. We'll get to tele-ICU, we'll get to telestroke, we'll get to telecardiology, we'll get to a lot of things, So why did the telemedicine picked up during COVID? So idea is simple. So not only in Nepal, the situation of doctor-patient ratio is bad, even in the developed countries, because doctors, the hospitals are short-staffed, and especially they are really short-staffed in ICU and super specialties. You don't have enough doctors, right? So Society of Critical Care Medicine in the United States, they came up with a plan because they had COVID. So all different hospitals, they were flooded with COVID patients, and everybody has to take care of the patients, right? And they didn't have critical care doctors enough, right? So what they thought is that they will just make a team of service providers. So this will be an ICU doctor, and under him will be non-ICU doctors, and then there will be ICU nurses, and under them will be non-ICU nurses, right? And they were like, each ICU doctor under his team was taking care of 24 patients or even more, right? And then even that was not enough, because not all the hospitals had critical care doctors. So then they came up with tele-ICU. I mean, it was already there. They jumped to tele-ICU. So what they would do is that they would actually, so sometimes there will be no doctor at all, right? There's no critical care doctor at all. So how would you do? So what you do is that you put on the tele-ICU doctor or ICU doctor on telemedicine, and you also have a parallel team of paramedics consisting of clinical pharmacists, nurses, whatever you need, right? And then they will be coordinating with each and everyone, and especially they'll be focusing on here. So that's a pyramidal system. So with that, with one telemedicine doctor, he could take care of 24, a lot of 24 groups, So one telemedicine doctor or one critical care doctor would now be able to take care of hundreds of patients, right? So that's the trick. And that's what they did. And fair enough, telemedicine or tele-ICU kicked off. It saved a lot of lives, problem kind of solved until they had more plans. So this is tele-ICU. What you do, so what you see in the picture, it's really complex, but it's very easy to understand. So this is a tele-ICU doctor, critical care doctor. So there will be a team of nurses and other paramedics will be involved. So you'll be in constant communication with them here, right? And sometimes you can actually see a patient, with a video, audio visual, right? And then the patient's monitor, EKG monitor or other monitors, they will be seen here. They are called physiological monitoring. And if you want to look at the X-ray or CAT scan, you have PACS monitor, right? And after all, you need the EMR, online EMR, right? Where you can see the labs, you can see everything, and you can put the orders, or you can write a note, so everything through EMR. So that's all you need. So to summarize, what you need is actually, you need inputs from 3 ways, So the first input you might need is audio input. So you talk to the patient, you talk to the nurses or the doctors at the bedside. So you need audio input through telephone. You can actually talk to the patient or the patient's family there through visual input or camera there. And actually you can look at the monitors or even at the ventilator through the camera, right? Because ventilators, they haven't been integrated yet, right? So you have to look them up. So these are your inputs, and of course you check on the labs and everything, notes and everything through your EMR. So what you need is, you need EMR, you need PACS to look at the X-rays and CAT scans. You need physiological monitoring to look at the EKGs or whatever you want to look. And also nowadays there have been clinical decision supporting apps. So there's been different apps that have been out there where they can categorize the patients based on Apache score. So in ICU, we use different score. You can use Apache score, SOFI score, whatever. And those scoring system, they can predict the prognosis of the patient. So based on those Apache score, you can actually prioritize who is the sickest patient there and who is less sick. And based on that, you can prioritize your work, So it's all technology. So it's a complex slide, but what I'm trying to show is that the intensivist could be remote, and he needs all these 3 inputs, and there will be a really good connection, internet, that's really important. So you need bidirectional audiovisual link, you need data transfer, information management, reliable network, everything. So it's complex. The biggest thing you need is you need a team, and you need a really good IT with the internet, And it's good for Nepal, because Nepal, we already have 40 Mbps or even higher, dedicated IPS lines you can get. So that's really good. We have fiber optics, right? So it's good. So actually tele-ICU can be even broadened, because through the tele-ICU, you can actually connect to the blood bank, you can connect to the pharmacy, you can actually sync with other hospitals, and you can even sync with clinics, you can sync with ambulance and the emergency, you can even sync with the mobile apps. And recently we're talking about the patient portals, like you can have patients glucose monitoring thing or EKG loop recorder, whatever. So you can actually integrate those. So you can have real database of the patients, and you can provide a live teleconsultation. So let's talk about the impacts. So there's been a lot of studies. I think this is from 2018. So you can see that they did a lot of studies. So they were actually dividing the patients in the ICU, those with telemedicine and those without telemedicine. And if you look at the curve, so patients who had regular care, on top of that, they had telemedicine care, they had more survival. They had survival benefit, stands out, right? So telemedicine actually, or tele-ICU actually, adds to survival of the patients, and it's proven. And so there's been a lot of other researches, studies. So the Society of Critical Care Medicine in the United States, they have mentioned that it saves life, it usually adds on to decreases your mortality and morbidity in the ICU. It decreases your length of stay in the ICU, right? And overall doing so, you'll actually be saving cost. There will be cost benefit as well. And also you'll not be hiring a lot of doctors, right? So you need one ICU doctor, he can take care of 100 patients. So you'll be actually saving a lot of money, right? So to summarize, the benefits of tele-ICU is that you have reduced length of stay, you have constant coverage, you have decreased mortality, you have decreased burnout of the physician, because critical care doctors who don't want to work in the night, they can have nice nap, and the other doctors, tele-ICU, will take care of them. So there's a lot of benefits, and this is from the remote ICU I work with. So how to implement tele-ICU, if you're talking about how to implement tele-ICU in Nepal. So it's going to be a phase wise. So what you want to do is that first you want to make sure the receiving team or receiving hospitals who want to get tele-ICU support, they get the idea and they are ready with it, right? Ready in the sense they have the team, they have their administration, they have the budget, whatever, they are ready with it, right? Or maybe it's a government. If the government is ready, that's the first step. And then you need to go for planning. So in planning, we'll go for detailed project planning. So you look at the human resources, you look at the infrastructure, internet, IT infrastructure, EMR, look at all those things, right? And of course, the budget estimation. And then we'll do the training. We'll do training of the local people, because it's always better to empower the local doctors and nurses so that the process becomes smooth. And then we go for implementation. And as we implement, we get the monitoring and feedback loop. And based on that, we improve ourselves and the team. So it's a phase-wise. So our experience in Nepal. So so first we started actually with the COVID. So we're actually working with CCMC. I'm glad to see our colleagues there. And so when COVID hit in Nepal, we were in panic mode because we didn't know what to do, right? So, and the government had actually mentioned that the patients should be staying home because they didn't have enough beds. But the problem was that who is going to monitor the patients at home, right? There was lockdown, there's not enough doctors. So the idea was to do remote monitoring of the patients at home through telemedicine. That's where we started first. And we provided free telemedicine service for the people. And then we started commercially, we started like providing the service all over Nepal. First, we started from Kathmandu. It was really good. And then we got to learn a lot of things. And we're doing the triage system based on CDC. So CDC had a tele-triaging system. So based on the tele-triaging system from CDC, and also implementing our own Nepal Medical Council's guideline, we made our own tele-triage, train our doctors, train our nurses, and we went in a pyramidal system, just like I mentioned earlier. And then we rolled out the telemedicine care all over Nepal. And we had 24/7 hotline, you know. And then we really got motivated. And then we actually had agreement with NMA. And then we started, we also provided telehealth consultation for Nepalese out of Nepal. So that's a non-residential Nepalese association, right? Organization. So they reached out to us. So we started providing telemedicine care to people outside Nepal. So we had people from, especially from Middle East, Japan in the first wave. We even had patients from Europe, you know, and all of these people were Nepalese people, right? And they had problem with the communication or language or some other barriers or financial barriers. So they couldn't get proper care in the hospitals in their countries. And we were there for rescue, you know. And then in the meantime, American Nepal Medical Foundation, they reached out to us, and then we started doing tele-ICU care because a lot of our patients, they were getting admitted in the hospitals, in the ICU, and they would, of course, want us to provide our care. So we would do an MOU with the local hospitals. And also we worked with American Nepal Medical Foundation, tapped into doctors from United States, and we used to provide tele-ICU care. We started in Janakpur and I think Birganj, and that ran during the first and second wave. And then we were also awarded 2021 Best Startup Healthcare Award from International Organization.
I think you have exceeded your time.
Yeah, I think that's pretty much from my side. Yeah, tele-ICU is growing and I think the future is bright. Thank you.
Thank you, Dr. Adhikari, for the wonderful, wonderful presentation. You showed us how to do it, how to make it happen. So we can see that the telemedicine horizon is broadening and is expanding. Thank you, Dr. Adhikari. So I'd like to invite our Radhika ma'am to summarize the session, please.
Sorry, ma'am. Before summarizing, I can see ma'am Sanu, Professor Sanu ma'am here. Thank you, ma'am, for being present here. It's an honor. So our theme, role of nurses in telemedicine. Now there are so many presentations, excellent presentations, and excellent works going on. And I also see so many online participants, especially Professor Changji Chuang from Taiwan, Satya from India, and so many other online participants from Nepal. Thank you all for participating online. Thank you, ma'am.
Thank you, sir. This session is very important because our voice is nurses' roles in telemedicine. The presentation were very good, and I wish to conclude the session. The remote area role of nurses is very important. Nurses not merely work in health, but also in empowerment of women through lifespan. Through your presentation, it is the message to nursing professionals. but basic training, define and train nurses are with the core competencies are must necessary. And we have to work for the standard treatment manual, protocol manuals for the nurses to work in the remote area. And the concern, Gautam, thank you for your primary healthcare. This is very important because our nursing is the home-based care. Home visit, clients' needs and health problems identification and care accordingly is the job of the community health nurse. Our healthcare system has the public health nurse as such in the remote area also through the various healthcare systems. So telenursing must be based on the emergency nursing, can save the many lives and prevents the complication for their quality of life. Government must empower the nurses and should have to consider in the retention of nurses in their service setting. There is another presentation, use of smartphone in telemedicine. We are using and it is very popular. And in this case, dedication to the health services in remote health workers are most important. There is a portable health clinic tools was presented here. Basic health checkup kit, nurses needs, every nurses, community health nurses in the home-based services should have to provide the basic health kit. And healthcare system using nurses in all areas. So nurses' role in healthcare improvement in nation is very important, that government must be centered in nurses are a major part of the body system. After that, the Suruchi revolutionized the home-based nursing care through telemedicine. It is our goal, empowerment of people for achieving their own health through the nursing action. There are most challenges is among them legal challenges. In Nepal, there is no provision of the nurse practitioners. That's why the curriculum must be developed and the universities should have to work in this case. Awareness of people for provision of, awareness of people about the importance of nurse for their own health is most important. We nursing professionals should have work in this to go on the public. Challenges in trusting relationship to the nurses from the public parts. So at last, tele ICU care. We also, Kathmandu Model Hospital is using this tele ICU nursing, and some systems are for the tiredness of the healthcare professionals. Some systems, ritual systems, we were changed. The 3-shift nursing shift were changed to the 4-shift nursing shift. It is a pioneer work in the Kathmandu Model Hospital. Some of the, I have to share in simple yoga and meditation practices using CC camera monitoring to the patient with video call to the individual patient was practices. It was very useful. And so in nursing curriculum, now we have to include the telemedicine and telenursing also. Include the technological practical orientation to the all nurses is must necessary. Service provider, the nurses, some ritual standards must be changed. Very useful in the disaster management in like our disease outbreak conditions. The nurses are the vitals organs. So we can conclude from this session that nurses are vital organs in healthcare system, and public awareness about nursing profession is the key to expand the telenursing in all over the world. We have to lots of work on this telenursing and people's health. So there is a 4 P's for the telenursing: preparing, planning, preparing, providing, and performance evaluation are most necessary. Thank you very much for the quiet listening.
We have a wonderful session. Thank you very much for the presenter and our chairs. Please go through this survey form and fill up for us. Here is a scan. And now this is the time for our lunch break. We will
Small announcement. So after lunch, 1 o'clock, we'll have photo session. And we want a photo of all participants as well. So those who have not given your photos, please consult Dr. Rajkumar Dangal. Yeah, he's here, and he will be collecting the photos if you have. Otherwise, you will be taking your photos. Thank you. And after 1 o'clock session, we'll have photo session downstairs in the lobby, and then we'll join again in 1:30 here. The presenters who have not submitted the presentations, please submit your presentation here, and please scan this for your feedback. Thank you.
Hospital. He's a professor and also coordinator of DM Medical Oncology, and he's the current president of Nepalese Association of Palliative Care, and is also the advisor for the Telemedicine Society of Nepal. And I will also like to request Dr. Sanjeev Tiwari. He is the General Secretary of Nepal Medical Association to chair this session. Let's give him a warm of applause.
Now, after lunch session, the first speaker is Dr. Rajni Sakya. The title of the topic is Dholikhel Hospital, Kathmandu University Hospital Journey Towards Research in Digital Health. And to introduce, Dr. Rajni Sakya is working as a project manager at the Research and Development Division under the Dholikhel Hospital, Kathmandu University Hospital, Dholikhel Hospital, Department of Public Health and Community Programs, vision to be a center of excellence for the innovative and holistic approach to community-based healthcare and community development in developing countries. So let's welcome Dr. Rajni Sakya.
Thank you, sir. So I think most of the post-launch sessions are bored, but I'll try to be more informative. But I also agree, I think everybody agrees that we carry our health in our pocket, in our hand. So from the very morning, we have been discussing about lots of things about the telemedicine. And after this post-launch session, now I would like to connect telemedicine, digital health, and mHealth. So on behalf of Dholikhel Hospital, Kathmandu University Hospital, I am privileged to present here about the Dholikhel Hospital journey towards mHealth in research. So my colleague, Dr. Rajkumar, will be talking about the Dholikhel Hospital a bit after this presentation. So I would like to jump directly to the Research and Development Division. That is one of the division that is in Dholikhel Hospital. And the vision of Research and Development Division is to establish Dholikhel Hospital, Kathmandu University Hospital, and we call it Kathmandu University School of Medical Sciences as well, as the leading center of innovative, cutting-edge, and high research high quality research. So the mission is to improve lives of people through innovative, ethical and high quality health related research with multi-sectoral approach. I think for every every implementation of the programs have to be evidenced, and that is what research help to bring the evidence and to implement the programs successfully and to scale up the program, not only in the community or in the nationwide, but globally as well. So we have 18 researches completed, 20 ongoing projects, 22 plus collaborators, 19 plus sponsors, and 100 plus researchers working in R&D. So in this 100 plus researchers, as the theme guide today, there are lots of nurses. More than 50% are the nurses, and I would also highlight the role of nurses in this particular project in few slides later on. So the area of the projects that we are being covering are non-communicable diseases, infectious diseases and genomic surveillance, mental health, maternal and child health, health system, health behavior and promotion, and vaccine trials. So we have lots of collaborators and sponsors from all over the world, and these are some of the glimpses from North America, Asia, Australia, Africa, and also Nepal. So we have some partners from Nepal, like World Vision, Medic, Possible, Nepal Health Research Council, and so on. I can see lots of faces, the stakeholders that is being partnered with our hospital and all over the world. Thank you. So now coming to the particular mHealth researches and programs. I already said there are lots of researches going on, but now I will be talking about the researches and programs. Only the 6 programs. So here the first one and the 6th one is the program. Beside that, others are the researches. So in brief, WDF project, that is World Diabetes Foundation project, that is Nurse-led continuum of care approach for addressing diabetes in Nepal, and Ocean, that is optimizing a community health program for hypertension in Betanchok and Pascal municipalities of Nepal. And third one is the MIRA project, that is an implementation study of mHealth integrated model of hypertension, diabetes, anemia, and antenatal care in primary care settings in Nepal. And then fourth one is a GDM project, that is development and testing of mobile health application for management of gestational diabetes. And fifth one is about the mental health, that is sensing technology to personalize maternal depression treatment in low resource settings. And the sixth one is community health support program that is run in Dolakha. So now coming to the particular projects, actually I want to show you where the mHealth is being used and how the role of nurses is, what is the role of nurses in this particular project. Actually, what happens in this project is the nurses, there is diabetic nurse, we call it, they organize diabetes screening camp, and they register the everything of the participants, the people coming to the camp in the EHR system that is widely known, electronic health record system. And then if the client is found pre-diabetic or diabetic, then that will be counseled through the EDSs from the application. And then if the person is diabetic, then they will pre-diabetic or diabetic, they will get this card, and this card is then goes, the patient with this card goes to the Dhulikhel hospital, and it will again record the findings in EHR system in the hospital, and then the diabetic nurse will again follow up the client monthly. So this is how the workflow is go on for the WDF project. So in this 10 minutes, I will not be able to explain everything. So if anyone is interested to know more about these projects, then I will be reachable. So another is Ocean project. So what happens, like this is the project we just got approved from NHRC. And then for this project, like what happens is, so here, not the nurse, but FCSB, that is the female community health volunteer, who are the pioneers in health in Nepal. So we are planning to give a mobile device to the female community health volunteer, and with which she will also be provided digital sphygmomanometer. So she will screen the health, the blood pressure of these clients in the community, and she will give also health education. And if she is found hypertensive, the FCSB will not diagnose the hypertension, but if she found her or his blood pressure raised, then she will refer the patient to the frontline health worker, and then this frontline health worker will have all the digital recording system in that particular health facility, and the this frontline health worker will treat the participants from the health post level. That is the rural one, the grassroots level health system in Nepal, we say. And then that will be again like training and support will be given by the medical professionals from Dhulikhel Hospital and also from the government side to the frontline health workers who is working at the rural areas of Nepal. And of course, there will be policy support and government support. We seek to scale of this optimizing the health problems of the community level people, especially in hypertension. So now here comes this MIRA project. So what happens in this MIRA project is like we recently finished this project. Actually, this this project was intended to do the randomized control trial, but due to some constraints, budget constraints and all, we have to finish it with the implementation only. So we're developing the MIRA EDSS, that is with the collaboration of Public Health Foundation of India, London School of Hygiene and Tropical Medicine, UK. So when we were developing the MIRA EDSS to be used by auxiliary nurse midwife, we also came to know there is another app that can be used for the from the ANM for maternal health, especially for the antenatal care. So this green one we can see is the WHO ANC reference app. I think it is somehow similar to one of the presentation. I don't remember actually the name who presented it, but it was similar to the one presentation we came to know about in the morning. And then in this, what happens is like when the pregnant woman attends the ANC clinic, then the auxiliary nurse midwife will record the ANC details in like we implemented this in 20 facilities. 10 facilities were using the MIRA EDSS and 10 facilities were using the WHO EDSS. And on the top of that, she also records everything in the paper record system, because we can't get rid of paper system as instantly. So everything, whatever there is in the ANC card, that is in this digital health record system. So with this, it will help the ANMs and build the capacity, build the competency level of the ANMs to detect and counsel high-risk pregnancy. And then it will help early screening, detection, and timely management and the referral of high-risk cases to the higher center. And again, just like if I get some risk and I go to the higher center from the health post of Nepal, one of the remote health post of Nepal, then I can again come back to that auxiliary nurse midwife and to the same facility, and then I can continue my follow-up. So being myself as a pregnant woman, so this is how this all the workflow is worked. So coming to the another GDM project, okay. So this is also for the pregnant women. this is what happens in this project is like when the pregnant women come at the age of 24 to 28 weeks gestational age, then her blood glucose level is being tested. That is glucochallenge test is done. And then if she got diagnosed with the GDM, that is the gestational diabetes mellitus, then she will be provided the application, the glucometer, the digital sphygmomanometer. So what she can do is she can test her blood glucose level, self-monitor blood glucose level, and then blood pressure. And also there are some icons of this physical activity, and then how much food is being intake, and then also was educational videos about the gestational diabetes mellitus. And so with this all, like that have also the web portal to the doctor side, and then that will help doctor in the patient treatment and disease self-management by the client. And in this, seeing this web portal, and there are lots of things like I can't just I mentioned I can't explain everything in this smaller slide. So seeing this dashboard, and the research nurses also monitor the web portal and do the bi-weekly telemonitoring follow-up to monitor the patient condition. And then next, this is about the mental health in the postpartum depression. This is a bit complicated picture, but I'll try my best to simplify. So what happens in this project is the woman with depressed mother, the depressed mother will get the smart watch, and the baby will get the beacon. So this is a picture of baby. So here is the baby has got beacon, and then this smartwatch and beacon is interconnected, and then it will see the proximity of the woman to the infant. Speech, it will also, this smartwatch will also collect some speech and environmental sounds, but not exactly the verbal clips, but only the essence of the clips. And then physical activity and GPS location. And then what happens is this is collected in mobile phone through electronic behavior monitoring application. And these all things will go to the counselor app. There will be the app that is being used by the counselor to counsel the depressed mother. So with this, the counselor can see if really the woman is in depression stage or not. Then the counselor will go to the community and again verify if really the woman have or depression and she needs counseling or not. Then after that, she gives the counseling to the depressed mother, and it is an intensive process for 4 weeks, and it has very good outcome as well. So actually this is Stand Strong 2. This Stand Strong 1 was implemented at Chitwan, and previously it was like the woman did not get this smartwatch, but only the application. But now it is being transferred to smartwatch. Everything is smart, I think. So next is this is about the community health support program that is run at Dolakha. So we also use Android mobile app that is used by the community health workers, and where they register household, conduct guided health assessments, provide basic medicine and health care, and also report danger signs or referring patient to the clinic, and that the data is get synced to the health facility. That should be the one hub facility. And then there will be one person that will be the CHW, that is community health worker supervisor, utilizes this CST to mobilize and connect CHWs, that is community health workers, ensuring they are equipped with evidence-based resources, continually trained and support through proactive supervision. So these are the resources and the programs that is particularly focused in the AM Health. There are lots of challenges and then barriers that we have faced. But it is not able, I'm not able to explain everything here. So if you would like to reach me, you can reach me individually and institutionally as well. So these are some of my references. You can see about the GTM project here. And then for the Stand Strong, what type of application is this, and all this is in Nepali. And then this is the reference for WHO application for the ANC. And this has been also implemented in some other countries like Rwanda, Tanzania, and Indonesia. So I think I'm on time, and without acknowledging my colleagues, research assistants, research assistants, technical teams, coordinators, investigators, and international investigators, these programs would not have been succeeded. And we look forward for more collaborations and networking to build a similar platform, especially in Nepal and also around the world. So I think everybody agrees this digital health and M health have to go on open source code. So we also follows the same. So that's the last slide for my presentation. Thank you.
Namaskar, good afternoon. Now I want to introduce Dr. Rajkumar Dongal. His title is Telemedicine in Rural Healthcare, Some Experiences, Challenges, and Project. He has largely devoted his clinical work in rural healthcare, including 1 year of dedicated telemedicine work in rural healthcare, MACD, of Center for Rural Healthcare and Telemedicine, under FEC Nepal. Recently, he worked in Dolakha Hospital, Dolakha, which is an outreach hospital of Dhulkhel Hospital, for about 2.5 hours. Right, and he has been working there for 2.5 years. Dr. Dongal has passion for working and advocating for undeserved and unreached population, and is currently pursuing fellowship in Global Health of Heal initiative at University of California, San Francisco as well. Dr. Dongal is a general practitioner and emergency physician, currently working as lecturer in Department of General Practice and Emergency of Dhulkhel Hospital, Kathmandu, University Hospital, Dhulkhel, Nepal. Dr. Dongal completed his medical school from Hebei Medical University, China in year 2010, and residency in general practice and emergency medicine, MDGP and emergency medicine from Institute of Medicine, Nepal in year 2018. And he was under me at that time. I want to introduce him. Oh, thank you.
Good afternoon, everybody. Namaskar. Thank you, respected chairperson, respected delegates, my senior colleagues, friends, ladies and gentlemen. It's my privilege and honor to be here in front of you and present some of my previous experiences and some of the recent advances going to be in our Dhulkhel Hospital. So let me continue. So here I'd like to acknowledge Telemedicine Society of Nepal, Dr. Uday sir and team, FEC Nepal, respected Professor Saroj Dhital sir and team, of course, respected Mahaprabhu sir for my support for me and all the motivations, and of course, Dhulkhel Hospital team, including Dr. Viras. Okay, so here I would like to share some of the experience some 4 or 5 years back. So in Magdi, Nangi, the remote village, at least 4 or 5 hours travel from the Beni, very serpentine, very muddy road. So there is a rural setting for the telemedicine, of course, through the Center for Rural Healthcare and Telemedicine, CRST, through FREC Nepal. So there has been a huge experiment also, and that's also a huge try also, I say. And at that time, there was, of course, some good experience of delivering service to the underserved population, remote population. So we could establish the telemedicine gadgets and services. The hub was the center where I used to stay with my colleagues and medical officers, and around there other health facilities, which were usually government facilities, health post and sub-health post, they were overseen by the hub center. So that was the experiment also, and somehow successful. And that was the scenario. So that the picture on the right, that was the hub center, health center with the operating theater facility also. That was far away remote. With you can see the geography, topography of the picture. Okay, thank you. So that was the operational modality. So red one hub, that was the picture on the right, just before that. And there are supposed to be mobile units with the medical officer or general practitioners, and then other village units that may be the our own operated village units or the health post operated by the government. So we try to establish that kind of model of the healthcare. And so yeah, the same picture, and these are interconnected by the ICT. And that's I would like to mention, of course, the network connection over there was all mostly provided by Dr. Mahavir Pund. His efforts, the network already established far long years back, and that is a so innovative and so appreciating job. And we use that network to establish that kind of telemedicine service. So here, I'd like to go into another aspect. I just going through some of my colleagues working in the different rural setting in Nepal. So recently, so I was just asking personally, what is the current status of telemedicine service in your center? So I could see, you can see the red marked things there, they have no telemedicine service or even set up in most of the district level hospitals. Some of the faint pink, you can see these centers, they have partially functioning or somehow just slowed down telemedicine services. And from this, we can appreciate, we can think that most of the telemedicine service is still, we are advocating for the rural healthcare and distant healthcare services. And Didal sir was afraid of, being handicapped, or kidnapped this healthcare delivery system, though we are advocating for the rural healthcare and distant healthcare by still maybe urban healthcare system. And I also afraid the same. I would like to go to now my work facility, Tulika Hospital. Tulika Hospital has been pioneering in community healthcare services for last more than 25 years, and it has 17 outreach centers. They work like the health post facility, and one outreach community hospital is located in the Dolakha. Previously, it was Gauri Sundar Hospital under FREC Nepal also. And now recently, from 2021, they have established with the telemedicine service to at least 4 outreach centers in Kavrej, in Palsok, Solukhumbu, and Nuwakot, and they have just started to function. And then this program has been implemented in collaboration with the ANSEL, and it's a huge project actually. And the tentative plan is in near future, the telemedicine project will be implemented in all the 17 outreach centers and will be monitored, especially through the outreach community hospital that's located in Dolakha. And this is one of the example of the outreach center and the new gadgets for telemedicine being installed and the telemedicine service is started. We started with the telepsychiatry, teledermatology, and some of the teleradiology services that's easier to start with and more informative and useful. Here, the Dolakha Hospital, this is the Dolakha Hospital, this outreach hospital located in Dolakha. So it's supposed to be, the future plan is this will be going to be the hub for all the outreach centers, for the 17 outreach centers. And these outreach centers in this picture, you can see located in different parts of the Nepal. And the concept is in near future, hopefully these this network of the telemedicine service can be integrated with the national or other health facility as well, so that we can deliver a very integrated kind of healthcare service to other underserved population as well, not only the network of the Dolike Hospital. So some of the challenges and the possible way forward, many people have already talked about many things. The technical aspect, human resource constraints, financial constraints, and intersector coordination. These things many people they have already mentioned. But here I'd like to highlight, the immersive training part, which I have mentioned here, and Udit sir was also highlighting a few days back. The concern is digitalization of the healthcare workers and people. So we can digitalize banking system, we can digitalize, we can work, we can talk and chat and Viber, Facebook, WhatsApp, and so many things. And then why we can digitalize healthcare system? And we have bank in our hand, then how we cannot have healthcare system in our hand? And we can, and now we are talking about so many other digitalization, then why not in healthcare system? So digitalization of healthcare workers and other people is really important. And I think Telemedicine Society of Nepal plans to implement to address this problem by providing some framework for the training of the medical healthcare workers and also some other people as far as possible. And that's really appreciable. That's concept, I think, from Telemedicine Society of Nepal. And some of the other aspect, human resource aspect has always been a concern. People, they don't tend to go out to community. And this sounds like telemedicine, staying away and then giving health services to the community, staying in Kathmandu or Pokhara or somewhere, and somebody not reaching out to community, then maybe that's not really the concept. Okay, I think healthcare people, workers can only facilitate. They cannot really do every job is staying in Kathmandu somewhere using some gadgets or some network. Okay, so I think some of the very highly motivated people should be reaching out to the community, facilitate the work. Of course, it's going to be cost effective. It's going to be very effective. Efficiency will be high, but we will be in need of highly motivated healthcare workers. And these are the real concerns and challenges. And I hope that will be addressed by concern of the many people. And for prospects in regard to the rural healthcare, many people also highlighted some of the many things related here. But here I'd like to highlight telemedicine has become now new normal. So just the new normal in COVID era was mask, distancing, these kind of things. And now I say, many people also say, I think they agree with this new normal. This telemedicine is the new normal. This is what we are going to agree with. This is what we are going to embrace, healthcare delivery system. And also it means to forward triage for the patients who are triaged before they visit to the emergency department or even hospital. Some people, they are supposed to reach some neuro hospital, they reach out to somewhere general hospital. Some people, they are supposed to reach to some another facility, they don't know where it is. So I think pre-hospital triage is another prospect of the telemedicine that also applies to the rural healthcare also. And I think this is a doorway for a specific service to the remote rural setting. We have already been listening so many things, including the tele ICU, of course, robotic surgery is already there. And I think another big prospect, very high burden of population, they fall into these three categories: family medicine, primary care, telepsychiatry is biggest. If we look through the DL or disability as life years, the mental health problems are the biggest burden in this world. So addressing this biggest gap and biggest problem, I think telemedicine is the one which is very much promising. And geriatric care, of course, old age population is growing. We all are growing. We have everybody growing up, and the geriatric care, the addressing geriatric care, because they are not really able to attend the hospitals, it's difficult, so many transportation constraints, so many financial constraints. But addressing geriatric care, I think that's another prospect. And people staying in the community, in the rural setting, I think this is another prospect for them. So another thing, teleradiology, of course, I have been practicing for years. I have been sending X-ray pictures and ultrasound, some of the clips, and then consulting and finally making diagnosis and writing the reports and doing some interventions, treatment, and sometimes even proper diagnosis, then finally refer to the Higher Center for proper management. So it has already been in practice. It looks very promising, even including CT scan, MRI, reporting from the distant, sending films from Nepal to America or Canada or somewhere, and getting back the reports and then making interventions. It's really promising, and it appears promising for the rural healthcare as well. Teledermatology, of course, dermatology has been always, I mean, if you just look the lesions or skin problems, then you make the diagnosis and you can advise for the treatment. And skin problems are one of the very common disease problems prevailing in our society. Also, cardiology, especially when we practice with the echocardiography, I also keep on doing while especially in the emergency department to make the proper diagnosis, early interventions, and it looks very promising with the ECG also that can be digitalized. We have also those gadgets which digitalize and we can send straight and forward method. Of course, telecritical care, people have been talking a lot about the ICU, tele-ICU, and so many things. Of course, this appears in Dhamaka also. We have been providing neuro ICU care service, but we used to have mostly pediatric resident, and we used to talk with the senior consultants and other people whenever required, but through, of course, using our gadgets or even WhatsApp or Viber also. That also looks very promising to provide the critical care service in the rural setting. So what I would like to say is telemedicine is the future, of course, and we need. This is the gateway. This is the thing we can strengthen the rural healthcare for everything to achieve the goals of the primary healthcare. Multi-sector coordination and support for everybody, including the agriculture, food and safety, and government, non-government, so many organizations. This is very paramount, very important. And I think while from our experience working in especially in the MACD and also now in Dhulikhel around also, the platforms which are talking about for the rural healthcare, but they need to be very user-friendly. We want the platform which are like WhatsApp. We want the platform like the Viber or Facebook Messenger, so that everybody, every community, at least every household, if somebody, every person cannot, but every household can reach out to for the healthcare delivery system, and that then only we can reach out to the community for the proper rural healthcare services. And finally, I would like to say the telemedicine is growing up, and again, I wonder, or I'm afraid of the business and the money, if it comes into play again, and every healthcare system, every gadget, every person, every training will be centered in the Kathmandu or some kind of urban hospital setting only. And again, it's going to be another foul play. So I would like to request everybody to make some step forward to address the rural healthcare, the gap, and make the future of the underserved, underreached populations. Thank you.
Now our next speaker is Dr. Shailendra Kumar Dual Srestha. He is from Armed Police Force Hospital. The topic he will be talking about telehealth, our early experience in uniform hospital. Dr. Shailendra is a consultant orthopedic surgeon in Nepal Armed Police Force Hospital for last 19 years. And he had opportunity to work in medical division during the COVID crisis period management center. And he also actually participating in different disaster response also. Welcome, Dr. Shailendra.
Thank you, Chair, sir, for giving this opportunity. I would also like to thank Dr. Uday for inviting me to talk on our experience. To telehealth, our early experience. Being a member of a uniformed hospital, we share a different kind of service scenario, and telehealth was a new thing for us. In the back, Nepal being a beautiful country, we are always prone to the natural disaster. Apart from the disaster, COVID-19 was a new lesson that taught us that the simple medical care can be a difficult task. And as a member of APF, when we were dedicated for a COVID service, our normal troops, they were deprived of a regular routine care as well as COVID. So the patient from the different part of the country used to contact us through Viber, WhatsApp, and other social media for the regular routine health problems as well as for the COVID problem. So group of our medical professionals IT professionals gathered together and thought of something which could help in future also. So we came up with the idea of formulating a telehealth system. We named it Swastha, Specialized Wellbeing Assistance System, Telehealth of APF. I would also like to acknowledge Dr. Arun Neupani sir for giving us this beautiful name. And what is this system? It's a web-based simple application. It works on the all types of devices with minimum configuration, and a live video conferencing is also integrated in this application. And we usually use the specialist doctors who are in the referral hospital in our primary hospital can directly commence one-to-one video consultation with patient. For now, it only works inside our APF network where the intranet is connected. And we are planning to extend this service even in remote areas of Nepal and have a mobile-based application. So right now, there are 57 places where the intranet is connected, and we are in early phase of our telehealth. Like we are still crawling. So we have planned to phase it out in a 5 different phases, and we are in phase 1 right now. So our system and hardware requirements are intranet connectivity, laptop or mobile devices, web camera, speaker and headphone, a simple web browser, Google Chrome or Mozilla, and a TrueConf software for the video conferencing. So our telehealth system we have developed into the emergency module and the OPD consultation module. Right now, we don't use internet. We are using only intranet due to the data security issues and other issues. We are not using the emergency module, and we have been using only the OPD consultation module. In the OPD consultation module, we have 3 sub-modules: admin module, doctor module, and a patient module. In the admin module, the IT professionals, they create an account for a doctor as well as patient, and they schedule the doctor according to the availability in the hospital. And they help patient to book the appointment, and they can see everything on the master chart. On the doctor module, after the account is given by the IT professionals, I can look in